I just want to see their reaction. Seated. Notice anything? I need to thank Paul and Susan. The PFM was giving us problems, and mysteriously they all disappeared this morning. I don't understand. But let's see how it works, okay? We're going to continue on with the testimony. Oh, one other thing. I've had a scratchy throat all week. I tested this morning. I'm negative. So if you see me up here eating cough drops, it's a little scratchier this morning. So, but I just want to let you know I'm safe, I think. With the weather change, another cold. Okay, we ready to proceed, Ms. Sawyer?
We are, Your Honor.
Call your next witness.
State would call Troy Rudman to the stand.
Y'all have a good evening? I'm waiting for this weather to come. Thank God we're off Friday because that's supposed to start hitting Friday.
Yeah.
Okay, sir. I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, Your Honor.
Okay, once again, make yourself comfortable. You have an aerial mic there in front of us. If you wish to lower your mask, you may. Okay? I need you to state your name and then spell your name so this young lady can get used to your diction. Okay? Go ahead.
My name's Troy Rudman. Spelling is Troy. Last name Rudman.
You guys hear him? You want some volume? Yeah. I know you got a little bit more in you. Okay?
It's early.
Give us a little more volume. Ms. Sawyer.
Thank you, Your Honor. Mr. Rudman, let's start with your background. Where did you go to college?
Yes.
And where did you go to college?
Mount Carmel College of Nursing.
Okay, and what degree did you get?
Nursing degree.
When did you receive that, Mr. Rudman?
In 2014.
All right, I'm going to ask you to speak up a little bit, okay, because I'm having a little bit of trouble hearing.
In 2014.
Okay. After that, what did you do after you received your nursing degree?
I took the boards for nursing and then got my license in July of 2014.
Did you work as a nurse after that?
Yes, at Mount Carmel West.
Okay. When did you become employed at Mount Carmel West, sir?
In August of 2014.
And how long did you work at Mount Carmel West?
Until July of 2019.
And what happened there, Mr. Rudman?
I was terminated.
At some point, because of your employment at Mount Carmel West and what happened, did you have to go before the nursing board?
Yes.
And tell us what happened with that.
It was a state...
I would just note an ongoing objection. Thank you.
Okay, I overruled.
Go ahead, sir.
It was a stayed suspension, so I still have my license.
Okay. And are you currently employed?
I am.
In a medical field or a non-medical field?
Non-medical field.
All right. Let's talk a little bit about when you first started working at Mount Carmel West. What were you doing at that time, sir?
I was hired on as a staff ICU nurse in the neurological ICU.
And how long did you work in that position?
About 6 months, and then our departments were merged into the entire ICU, so medical, surgical, cardiac, and neurological.
Okay. And what did you do at that point when they merged?
Staff ICU nurse.
How long did you hold that position?
Until January 1st of 2017, when I became a rapid response nurse.
Tell us what a rapid
hold
response
on.
nurse is.
Bring the volume up a little bit there.
In 2017, I became a rapid response nurse. That's a nurse that is tasked with going to every floor and trying to prevent ICU rebounds, so people that were transferred out of the ICU so that they didn't come back to the ICU, and also responded to code situations, emergent situations, and facilitated transfers from the step-down or the normal floors to the ICU.
Now, when you responded to emergency situations, what was your role in regards to that as a rapid response nurse?
So my role, I would show up. Anyone in the hospital had my direct line. They could call me. I would show up, analyze the situation, speak with the nurse assigned to the patient, and then basically do whatever was needed for that patient in that given time.
So you were all hands on deck?
Yes.
Okay. How long did you hold that position, Mr. Rudman?
Until December of 2018.
And what happened at that point?
I was put on administrative leave.
And how long were you on administrative leave?
Until July of the following year, 2019.
Which was when you were terminated.
Correct.
As a neurological ICU nurse, what were your job duties for that?
In the neurological ICU, we would deal with traumatic brain injuries, strokes, primarily patients that had any brain injuries or any acute traumas to the head or brain.
And you said you would deal with them. What were your specific jobs in regards to those patients?
As a neurological nurse?
Correct.
To monitor, to assess, to carry out orders given to me by a physician.
When you switched to just a straight ICU nurse, what were your job duties at that point?
The same role.
And at this point, what type of patients are you caring for?
Any patient, really. Any surgical, cardiac, neurological, general medical. It was an entire ICU that was a mixed ICU.
I would say for the years you worked at Mount Carmel West ICU, you became very familiar with the ICU unit. Would that be accurate?
Yes.
When you first started, what type of orientation or training did you receive coming straight from nursing school and your board and going straight into working?
So we were paired with an orientee, which was a tenured nurse on the unit.
Okay.
We followed them around and helped them in their day-to-day, so learned on the job for about 10 weeks, and then we took our own patients after that.
Okay. Was there any type of ongoing training at that point?
There were some health stream modules, which was the hospital's education department, and much past that, it was mostly on-the-job training.
And once you received your nursing license up until today's date, is it still in a valid nursing license?
Yes.
And you maintained all the continuing education courses you needed to do so in order to maintain that?
Yes.
Mr. Rudman, I'm going to direct your attention, and this has been marked as 15BB. Can you identify that for us?
That's Mount Carmel West.
Okay. And I'm going to show you what's been identified and marked for identification as State's Exhibit 15B. Do you recognize that?
I believe that's the family room we use for loved ones going through difficult situations, and it would be a place where the physicians could speak to them directly in a quiet, controlled environment.
And that's at Mount Carmel West?
Yes.
In the ICU area?
Yes.
Okay. And what's been marked for identification as State's Exhibit 15C, can you identify that for us?
I'm not sure.
Okay.
This might be the same room, but I'm not sure.
If I can show you. All right, certainly looks like it.
Yeah.
Would you agree? And 15D appears to be another angle of that same room.
Yes.
And then what I've marked for identification as 15E, do you recognize that?
Yes, there's the Pyxis machine in the back of the ICU.
All right, and that would be this area?
Correct.
15F?
The same.
Okay. Pyxis machine again?
Correct.
15G?
Another view of the same Pyxis machine.
15H?
Another view of the Pyxis machine.
15I?
Another view of the Pyxis machine.
And 15J?
The Pyxis machine.
All right, now tell us a little bit, what is the Pyxis machine? What type of, does that mean to you?
The Pyxis machine was used to get medications for our patients. It held any medication that we needed or used in the ICU. For the most part, we would scan our badge, use our fingerprint, and have a login, dedicated login for access to the Pyxis machine.
All right, so if you withdrew medication from that, did it create an electronic record?
To my knowledge, yes.
And it would show, because it's a login and your fingerprint, thumbprints used, it would show it was you?
Correct.
Can you identify 15K for us?
It's a room in the ICU.
And 15L?
The same room in the ICU, room 9.
15M?
Another view of the ICU room.
15N?
The ICU room with the patient's bed.
15O?
This is the back of the patient's room that shows the monitor.
Okay, and explain to us what the monitor and this whole area is for us.
The monitor was used to continuously monitor the patient, whether that be blood pressure, heart rate, oxygenation. There was also access to oxygen and suction on that same pillar next to the monitor itself.
Okay. And was that common for all of the ICU rooms at Mount Carmel West?
Yes.
15P.
That is the back of the room, which showed the sink and toilet that we could access.
15Q.
Sitting area in the patient room.
15R.
Another seating area in the ICU room.
15S.
The bed and the computer monitor that we would use.
How is this monitor different from the other one we talked about?
The computer monitor we would use to chart, to scan in medications. Really any aspect of our assessment was charted and utilized through that computer.
Okay. Now you just said you scan in medication, so once you withdraw the medication from the Pyxis machine, what do you do from there?
So from the Pyxis machine, enter the room obviously, log into the computer. We would scan the patient's ID band.
Okay.
We would also ensure that the order was under the correct patient at the correct time, and then we would scan in the medication itself under the certain time that it was due in the medical administration record.
So I'm assuming there's a bar on the medication vial itself?
Yes.
And is that the scanner area I'm looking at there?
That's correct.
Okay. And I probably should have switched the picture to 15T because that shows us a close-up. Same monitor?
Yes.
And close-up of what we just talked about.
Yes.
And 15U, again, same thing?
Yes.
15B, what is this?
That is the front nurse's station, and it has the front Pyxis machine to the right.
Okay. Explain to us why this is the front. Is there a back area also?
Yes, the first pictures were the back area of the ICU. It was a large unit, so
Okay.
there was multiple Pyxis machines throughout the different units because of the number of beds.
Do you know how many beds there were in the ICU at Mount Carmel
I don't
West?
remember the exact number.
Okay. And the back area you said we saw first, so this is the front area.
Correct.
Do you remember how many Pyxis machines were at the Mount Carmel ICU?
The main ICU, there were two.
Okay.
There was also a Pyxis machine in the CV ICU, or the cardiovascular ICU,
Okay.
which was next door. And then we also had a step-down ICU that had its own Pyxis machine.
Now, we've heard some talk that the ICU may have been on multiple floors.
Correct.
How many floors, sir?
When the neurological ICU was in existence, there was technically 2 floors, but they were split by multiple units.
Okay.
So there were, or 3 floors, I should say, with the step-down ICU. There were, the main floor held the medical ICU and the cardiovascular ICU.
Okay.
And then there was a separate floor for the step-down ICU, and the neurological ICU was across the hospital on a separate floor.
All right. Now, that's the first time we've ever heard anything about a step-down ICU. Can you explain what that is to us?
The step-down ICU was brought into being because we needed some overflow at times, and then also when there was a lack of beds in the hospital, and some patients were potentially too sick to be in a normal hospital floor, but not sick enough to warrant an ICU bed, we would have a step-down ICU that would help with that overflow, and that would be staffed by ICU nurses.
Okay. All right. 15X. What is that?
That is the front Pyxis machine.
Okay. 15Y.
Another view of the front Pyxis machine.
All right. Now, if you are withdrawing medication from the Pyxis machine, where do you go to enter your thumbprint and your ID code?
At the main monitor on the left, to the right, there's a small circle that would be used for our fingerprint.
Okay.
Hold on, you have a pointer.
Yeah, I was going to say, I think there's a laser pointer up there.
Would that help you?
Can you see if you can
Yeah.
point that out to us?
So this would be the fingerprint sensor on the Pyxis machine.
Okay.
This would be the main screen that we would use to input the information, and then the keyboard right
Okay.
here.
And where do you obtain the medication from then?
Depending on what medication, there was a fridge that held refrigerated items.
Okay.
There were drawers in this unit. There were also drawers in this unit, another fridge that had overflow, and then they called it a refrigerated section, but this was just a shelving system that held other medications as well.
So if you enter your thumbprint and your ID, does the drawer pop open, or do you have to actually physically open it?
So you would have to choose the patient
Okay.
that you were accessing medications for.
Okay.
Dependent on the medications that you chose, the various drawers would open after you hit accept that you were withdrawing those medications.
Okay. All right, so going on with the remainder of this, 15Z, what does that show?
This is the middle section of the unit. Behind this photo would be the Pyxis machine that we just looked at.
Okay. And 15AA, what is that?
This would be around the emergency department entrance of the Mount Carmel West Hospital.
All right. Mr. Rudman, those photographs that I just showed you, States Exhibit 15B through 15BB, do those show the hospital in the same or similar condition as when you worked there?
Yes.
True and accurate copy of what you saw in those working days?
Yes.
So let's continue talking a little bit about the Pyxis machine, Mr. Rudman. So who enters the actual order for the medication?
So the physician can enter the order through the computer. We can also take verbal orders and enter the order through the computer as well.
So if you take a verbal order as the nurse, which computer do you enter that medication order at?
Any computer in the unit can be used to do that.
Including the one on the Pyxis machine?
No.
Okay.
So that's specific to the Pyxis. The computer in the room or at the nurses' stations could be used to chart and enter orders. The Pyxis machine was a dedicated piece of equipment.
All right. So if you would get a verbal order, when would you typically, as the nurse, enter that order into the computer? Before you withdraw the medication, after the medication, somewhere else?
It depended on the situation.
Okay,
If it
explain
was-
that to us, please.
If it was an emergent situation, we would withdraw the medication, take care of the patient, and then enter the order after the medication was given.
Okay, and if it's in a non-emergent situation?
Usually the physician would enter that order as a scheduled order, and it would be in the computer put in by whatever physician that ordered it.
How would you be alerted to one that the doctor would enter?
It would show up as a timed administration or as a PRN or as needed medication in our MAR or medical administration record.
All right, so explain to me what as needed means to you as the nurse.
So as needed was oftentimes used for pain medications. If the patient was in pain, we would sometimes have standing orders for Tylenol or various medications for pain, or even if a patient had a fever, we would have PRN orders or standing orders that we could use as needed.
Okay. And in those situations, does that mean you don't have to wait for a new order from the doctor?
Correct.
We've also heard a lot about obtaining medication via an override in the Pyxis. Does that mean anything to you?
Yes, it was very common in the Mount Carmel Health System for overrides.
Okay, so explain what you mean by override when you say it.
An override would be any time that you would override the Pyxis to withdraw medication for any given patient. If you didn't have an order, or for some instances, there were also pieces of equipment or sterile water, saline that were in the large sections of the Pyxis that wouldn't necessarily have an order, but we would have to override to access that.
And when you're referring to override, does that mean anybody else is reviewing that prior to you pulling it?
Prior to?
Correct.
Not always.
Okay.
If it were in an emergent situation and we pulled the medication, it would potentially be reviewed after we had given the medication.
And reviewed by who, sir?
Pharmacist and the physician.
So what is your understanding that of what the pharmacy does when you pull medication from a Pyxis machine on override?
My understanding of their job, I don't really know their exact
That's fair.
protocols associated with that.
Okay. What if you wait for their approval? Tell us how that happens.
Within a medical administration record, when an order is placed by a physician or by a nurse, the pharmacist will electronically review the medication, such as an antibiotic. They might check for allergies or that the dosages are appropriate for the patient, and they could approve or deny the order.
Okay. How do you get notified of whether it's approved or denied?
Within the MAR, Medical Administration Record, it would show as an approved by the specific pharmacist that did that or denied.
So tell us what you're doing if you're entering a medication and then waiting for pharmacy. Where are you at and what are you looking at?
Depending on how busy we were. If it were a non-emergent medication, we might be attending another patient, assisting with another nurse, or potentially charting at that time.
Okay. And then how do you know it's been approved or denied?
We would have to check the MAR
Okay.
to verify that.
So you'd have to physically go into that patient's record, look at the MAR to know it.
Correct.
Did you ever have a situation where the pharmacist would call you about a medication order?
They could. I don't remember any specific time for myself as a nurse.
You talked about obtaining via an override, medication via an override in an emergency situation. What was your understanding of what an emergency situation would be?
An emergency situation would really be any situation where the waiting for any period of time could potentially harm the patient in any way.
Was there a crash cart that was available for any code blue?
There were several crash carts on every unit in the hospital.
Explain to us what would be on the crash cart.
Crash cart would hold a monitor, defibrillator, also medications that would be used in code situations or emergent situations, including saline bags, suction equipment, really anything pertaining to a code blue situation.
Would there be any medication on that crash cart?
Yes.
What kind of medication would be on that crash cart?
Medications such as amiodarone, epinephrine, really any medication that would be used in a code blue situation, and then the pharmacist would have access to that to help mix any solutions that were needed, such as Levofed or other drip medications such as those.
Okay, so those medications you talked about, Levofed, what is that used for?
Levofed was used as a medication when a patient were in shock, blood pressure was dropping. The vessels would constrict down, which would increase the blood pressure for the patient.
Is that what we have heard called a vasopressor?
Yes.
Okay. The epinephrine.
Hold on. You mentioned 3 drugs. Can you spell them? This isn't a test, okay? But this poor young lady's taking it down, so I was just getting the spellings for it.
We'll start with Levofed, Levophed. and amiodarone, AMIOORADONE, I believe.
It's okay, this isn't a test.
And then, what was the third medication?
Epinephrine.
Epinephrine. EPHIPHERINE.
She types phonetically, so helping her with the spelling is something I
Sure.
try to do. And I'm sorry for
No,
interrupting you.
that's perfectly fine, Your Honor.
I just want to keep her happy.
So what's epinephrine used for in a code blue situation?
Epinephrine is basically adrenaline, so it can be used to help jumpstart the heart when cardiac arrest occurs.
Okay, and the other one,
Amiodarone
That one.
is an antiarrhythmic,
Okay.
so it can be used when the heart is beating, but in various erratic heartbeats. It can be used to correct that into a normal, what's called a sinus rhythm or a normal heart rate.
Okay. Mr. Rudman, you've had some involvement in your role as a nurse with some of our victims in this case. So I'm going to direct your attention first to, and I'm going to start on this pen, to what I've labeled as 14G. Can you identify which patient this is regarding, sir?
Melissa Pennick,
And her admit date was what date, sir?
11/15/2018,
And discharge date?
11/20/2018.
Okay. And I'm only going to direct your attention to your involvement with Ms. Pennick. So, and is that big enough for everybody to see? Okay. So in the middle of the page here, is that your name at the bottom?
Yes.
And what date were you involved with Ms. Pennick on?
11/18/2018.
And what was your involvement at this time? And I don't think I asked you, did you work a specific shift during your time at Mount Carmel West?
Yes. Night shift,
And what hours were those, sir?
7 p.m. to 7 a.m.
And when you were specifically in the ICU, were there specific doctors you worked with?
In the ICU or as rapid response?
First as the ICU.
ICU, it depended on what service was on for the given patient.
Okay.
For the general ICU, it was either Dr. Husel or Dr. Hagras most nights.
Okay. So when you were in the rapid response team, you responded to the entire hospital?
Yes, ma'am.
So I'm not even going to ask how many doctors you interacted with.
Probably can't count that high.
Okay. All right. Tell us about your involvement with Ms. Pennick, sir.
So I was rapid response. From my note, it looks like I was called to bedside to assess a patient who was hypoxic or wasn't receiving enough oxygen.
Okay. Thank you.
When I arrived, patient was on a large amount of oxygen. They ordered ABG, or arterial blood gas,
You're good. Go ahead.
and a chest x-ray to assess the patient. The chest x-ray showed interstitial infiltrate, which could mean pneumonia,
Okay.
or some sort of respiratory issue
Okay.
going on with the patient. And then the arterial blood gas, as listed, from my recollection of reading ABGs, it's been a while, but
Okay.
it appears that she wasn't receiving enough oxygen and she wasn't breathing out enough CO2 to make her acidotic.
All right. And at this point, you indicate you're going to continue to monitor these symptoms?
BiPAP was placed.
What's BiPAP?
Which is essentially oxygen with pressure behind it, so it would
Okay.
help open the airway and deliver a higher concentration of oxygen.
Okay.
It's a step in between intubation.
Okay. And then I'm going to direct your attention to the next page. Again, is that your name?
Yes, ma'am.
What date is this involvement with Ms. Pennick?
The 19th.
So the very next day. What was your involvement with her at this point?
Looks like I was called back to bedside to assess. The same patient, still struggling with the oxygenation, even with the BiPAP that was placed. Again, we did another ABG, which did not improve from placing the BiPAP. And then at that point, I was in contact with the ICU charge nurse physician and decided to transfer to the unit.
Okay. And I notice it is the step-down ICU?
Yes.
So at this point, she's going into the ICU unit.
So you could go into the step-down ICU if potentially there were not enough beds in the main ICU.
Okay.
It could have been for that instance because there was no beds left.
Okay.
But it was, per my note, the step-down ICU.
Okay. Mr. Rudman, another patient you were involved with was Beverly Schertzinger. So I'm going to show you what's been marked for identification as State's Exhibit 3C. And can you identify the patient for us?
Beverly Schertzinger,
And her admission date
10/2/2017,
and her discharge date, sir.
10/9/2017.
And I'm going to direct your attention to the middle of the page here. Is that your name?
Yes, ma'am.
And what date was your involvement with Ms. Schertzinger?
10/10/2017.
And tell us about this involvement with Ms. Schertzinger.
So again, I was in my rapid response role. I was called by the standard floor to assess the patient who was hypotensive or low blood pressure.
Okay.
The vital signs when I arrived, blood pressure, obviously 84/47, which is low. She had had a liver biopsy prior to my arrival, and she presented with back pain and a rigid abdomen. They did a stat CT of the abdomen, which is an x-ray essentially, just a more in-depth x-ray. And it showed a small hemoperitoneum, which could be indicative of blood in the abdomen.
Okay. Go ahead.
So Dr. Mangan, who was the physician on the normal floor on that given night, they ordered a CBC, which essentially just looked at what her blood levels, her hemoglobin levels were, and then also placed a catheter to assess her urine output.
Okay.
Looks like her blood pressure dropped. A 1 liter bolus of saline, which is essentially fluid just to bring the blood pressure up, was given at that time. And the hemoglobin, which is a count of your red blood cells, were decreased, which suggested potentially a bleed from the liver biopsy.
All right. What else did you do?
Levofed was initiated because of the low blood pressure, 64/38. And anytime Levofed is initiated on the floor, it has to be the patient has to be transferred to the ICU for monitoring. Because
why is that?
The floor nursing, they're not trained or able to keep a patient with Levofed on the standard nursing floors.
Okay. So what happened next?
It looks like we increased the Levofed as much as we could. No improvement. Patient was intubated at the bedside on the standard floor. And at that time, a code blue was called because the patient lost her heart rate, her pulse. We did 2 rounds of CPR and then transferred her to the ICU. At that time, the family decided to withdraw care.
Do you remember this patient at all, sir?
I do not.
So this is all from the medical records?
Correct.
So do you remember whether or not you were at the bedside at the time the family decided to withdraw care?
I'm not sure.
Okay. And in this note, does it note whether you were involved in the administration of any medication for her at the time they withdrew care?
Not in the note, no.
And if you had been involved, would there have been a note regarding that?
Usually, yes.
Okay. All right, so the last patient I want to talk to you about is Ryan Hayes. And this is State's Exhibit 2E. Can you identify the patient for us, sir?
Ryan Hayes.
And his admission date?
4/2/2017.
And his discharge date?
4/4/2017.
And Mr. Rudman, fair to say you're very familiar with this patient?
Yes.
Why is that, sir?
This was the patient where I administer medications and was the subject of the nursing board hearing.
Okay. So let's talk about,
No, ongoing, good.
I'm sorry?
Just my ongoing.
Okay.
all right, I want to direct your attention to April 3rd of 2017, which is our medication order we're going to talk about. What was your role in the hospital on this date?
Rapid response.
So what happened that called you to the bedside at this point?
In this instance, the ICU called me
Okay.
because they were very busy, as they were most nights. The patient, or the nurse in charge of Mr. Hayes, was getting an admission from the emergency department for a full arrest.
And do you recall who that nurse was?
Tyler Springer.
Okay, so what happened when you got up there as rapid response nurse?
I met Dr. Husel and Tyler Springer at the Pyxis, where I received a brief report about the patient and the orders given for the palliative withdrawal.
Okay.
And the explanation that they had another patient to attend to.
Okay, and what were the orders you were given for the palliative withdrawal medication?
1,000 of fentanyl,
Okay.
10 of Versed, and 10 of Dilaudid.
Okay, and did you withdraw those from the Pyxis machine, sir?
I withdrew part of the order.
Okay.
Tyler Springer had initially began withdrawing when I took over assistance.
Okay, so at the top, this would be the order for the 1,000 micrograms of fentanyl,
Correct.
and it says IV push. What does that mean to you, sir?
Given intravenously, IV as a push rather than a slow drip through a bag of medication.
Do you recall how many vials of fentanyl you would have had to withdraw to meet the 1,000 micrograms?
I don't.
Okay. And then I'm going to direct your attention to the next order on the page. What is this, sir?
Hydromorphone or Dilaudid.
Okay, and how much of this were you to withdraw?
10 milligrams.
And on the next page, what is this?
Midazolam or Versed.
Okay, and how much did you withdraw of this?
10 milligrams.
And approximately what time did all of this happen on April 3rd, 2017?
It looks like around 22:53 per the records.
So once you withdrew this medication, Mr. Rudman, what did you do with it from there?
After I withdrew the medication, I met family at bedside and withdrew the medications from the vials, medicated Mr. Hayes with the medications that were ordered, and then extubated the patient per the orders and the family's wishes.
How many syringes would you have had to have used, sir, if you remember?
I don't remember.
Okay. Would all have gone into one syringe, or would you have done them separately?
Objection, said he doesn't remember.
I will permit it.
I don't remember.
Okay.
Usually it would be separate.
Okay.
Objection, move to strike the anything after I don't remember.
I'll permit it to stand overruled.
And Mr. Rudman, you withdrew these upon the order of Dr. Husel?
Correct.
Did you, in fact, administer these medications to Ryan Hayes at that time?
Yes.
Now, you had just come to the floor. At any point, did you have the opportunity to check Mr. Hayes' medical records?
I did not.
Did you, prior to administering these medications, enter any type of pain score into the system?
I did.
Okay. And I'm going to direct your attention to the next page. Can you show us where you entered the pain score?
It was 4/3/2017 at 22:57.
And you entered a 10 at that time.
Correct.
At any point, did you review prior to that the last 2 days' worth of pain scores that showed 0?
I don't recall.
Okay. Do you recall what Mr. Hayes' injury was, why he was there in the ICU?
I received a report by Tyler Springer, the nurse, and Dr. Husel prior to administration of the medications that he was a 39-year-old male with polysubstance abuse history. He was found down by a family member in the bathroom after an undetermined amount of time. When EMS was called, they did multiple rounds of CPR, eventually brought him to Mount Carmel West, where he was resuscitated again in the emergency room, and then transferred to the ICU. So
That's the information you had.
anoxic brain injury related to a drug overdose was the information I had.
Why did you put the pain score of 10 in there, sir?
In hindsight, with the
Objection, Your
CPOT,
Honor.
Okay. The question is why, it's sustained. The question is why did you put the 10 down?
for the pain scale, we were taught as nurses that palliative extubations, the process of dying, was a very painful event. So we were putting pain scales as anticipatory pain for comfort care related to palliative extubations.
So this 10 is anticipatory.
Correct.
Now, the CPOT, is that the instrument you used in regards to this?
Correct.
Are you aware that that only goes up to a pain score of 8?
Yes, ma'am.
Okay. Then why the 10?
In haste, it was an error.
Okay.
I was going for the maximum pain level.
Other than anticipatory pain, did you see any other indication of pain in Ryan Hayes before you administered these medications?
I don't remember.
Okay. The fentanyl, what type of medication is that?
An opiate?
And the hydromorphone?
An opiate?
And the midazolam?
Sedative?
Now, when you pulled these medications from the cases, did you await pharmacy approval?
I did not.
So you pulled these via an override?
Correct.
Why would you do that when typically you wait for pharmacy approval unless it's an emergency?
Really, any time I was called, it was of some urgency, as I was the only nurse as a rapid response at any given time. So if a code blue were to be called, that would be where I would have to go, and it could be across the hospital at any given time. In this instance, the family had traveled all day and were at bedside because some loved ones were coming from out of town, and it was a palliative extubation that was planned during the day but was completed at night because of that family dynamic.
So in your eyes, this was an emergency?
Yes.
Your Honor, if I can have a moment?
Yes.
Mr. Rudman, do you see Dr. Husel in the courtroom here today?
Yes.
Could you please point to him and
Stipulate to identification.
Okay.
Okay. Again, they're agreeing that he would identify Mr. Husel, so.
Thank you, Mr. Rudman. I have no further questions, Your Honor.
Ms. Menashe?
Thank you, Your Honor. One moment. Oh, are you exhibit? Oh, I'm sorry. Do you need photos? No. Sure, I'll have the photos. Morning.
Morning.
Diane Menashe on behalf of Dr. Husel.
Nice to meet you.
Nice to meet you. Just want to, got some follow-up questions, as you might imagine. I'll start from where you ended, if we could. Fair to say that when you were called as a rapid response nurse to the ICU with respect to Mr. Hayes, you understood that it was a palliative extubation.
Yes.
And you just testified to that it is your understanding that the decision had been made by Mr. Hayes' family to palliatively extubate him during the daytime shift.
Yes.
And that there was a pause or a gap in time between the decision and the night shift because family members or a family member was coming from out of state.
That's correct.
When you were at the Pyxis machine with Mr. Springer and Dr. Husel, you were then, as you testified to, provided with some information with respect to what medication had been ordered for the extubation. Is that correct?
Yes.
Fair to say that your intent at the time in administering the 1,000 of fentanyl and the 10 of Versed and the 10 of Dilaudid was to provide comfort to the patient.
Yes.
I want to go back to the Mars with respect to Mr. Hayes, if we could. In preparation for your testimony today, did you have an opportunity to review the entire medical administration record for Mr. Hayes?
Yes.
And I just wanted to ask you some follow-up, because while you testified that in hindsight it was an error to write the 10, you're aware, are you not, that after the 1,000 and the 10 were administered by you, that a different nurse actually indicated that that medication had not relieved the pain of Mr. Hayes?
After reviewing, yes. I was not present during that administration.
But now, and I'm asking this because of your answer on direct, you are now aware, are you not, that a totally separate nurse, Nurse Springer, is that fair to say?
Yes.
Had indicated actually on the Mars that the 1,000 of fentanyl, the 10 of Versed, and the 10 of Dilaudid had not relieved Mr. Hayes' pain.
That's correct.
And that was actually indicated as a pain relieved no. Would you agree with me?
Yes.
And I'm just generally about Nurse Springer. I know you've been asked about this previously. Fair to say that that's a nurse that you trusted?
Yes. I actually went to school with him.
You went to school, and I think I remember also that you did orientation together. Is that fair?
We started at the same time.
And so someone that when you worked with him, you had no reason to doubt his credibility or the things that he might say or do?
No.
If I could, tell me with respect to, and I'm trying to just, showing you what's previously been marked as States Exhibit 2E. When you are entering in the pain scale, and you were shown this on direct, does this look familiar?
Correct.
10 is noted multiple times by you. Do you see that at 2257?
Yes.
Okay. And is 10, is that something that you manually entered?
Yes.
Fair to say that in your career as either a rapid response nurse or an ICU nurse, this isn't the only time that you've ever entered a 10?
Correct.
And just so we're clear, there's a little number 11 and a number 12 here. If you know, what do those indicate?
I'm not sure.
Okay. And you reviewed this document in advance of your testimony today?
Yes.
And would you agree with me that the entries from Nurse Springer are 19 minutes after the indication that you put as a 10? Would you agree with me on that?
Yes.
And tell the members of the jury, fair to say that like 15-minute checks are kind of standard operating procedure, is that right?
Yes, after pain medication administration.
After pain medication administration, then there's like 15-minute checks to see if the medication's working or if it's not.
Yes.
You had mentioned that Mr. Hayes had anoxic brain injury and was an overdose situation. Is that correct?
Yes.
And also, I just wanted to note one other thing, if we could, going back to this. I know you testified on direct that by entering a 10 into the system, you consider that like anticipatory pain, right?
Yes.
And would you agree with me that anticipatory means I'm doing something in advance of something else that might happen?
Yes.
Okay. And so I just want to make sure that we're clear here that the order date and time for the fentanyl was 2253. Is that correct?
Yes.
Okay. And your last updated, and it indicates 2253.
Yes.
And then if we can go to the pain charge, it's 2257 that you enter 10.
Yes.
You mentioned with respect to Mr. Hayes that you were called to ICU, and I wrote down because the ICU was very busy, as it was most nights. Let's talk about the night of when you were called for Mr. Hayes. ICU was busy that night. Tell me, you don't remember the number of beds in ICU, correct?
Correct.
But fair to say that sometimes, even during the night, that the ICU was so full that someone might first have to wait to get to the ICU and go to step down.
Yes.
And the night of Mr. Hayes being a busy night in the ICU, that is not unusual.
No.
And in addition to the nurses and charging nurses and the physician on the ICU, there was always the capability of someone at the ICU also calling a rapid response nurse, such as yourself, correct?
Yes.
There's kind of lights are on the ICU at night, is that fair to say?
Yeah.
Things are active.
Very busy.
I want to talk about, if we can, Beverly Schertzinger. Showing you what's been marked as State's Exhibit 3C. Fair to say that, absent your review of these medical records, you have no independent recollection of this patient, do you?
I do not.
And did you review her entire medical record in preparation for your testimony?
Not the entire record.
The testimony you gave with respect to Ms. Schertzinger, your involvement was prior to her getting to ICU, or was it both before and after she got to ICU?
Before and after.
Okay, so I want to talk to you about showing you what's been marked as Joint Exhibit 3, page 817. First of all, just generally, what does this sheet appear to you if you recognize this type of document?
These would be the code notes.
And who fills out the code notes?
A nurse, usually.
Is this your signature right here?
Yes, ma'am.
And so before I asked you questions about it, I wanted to make sure that that's your signature. Can the jurors still see? Great. So does it appear that this code sheet relates to patient Schertzinger?
Yes.
I want to just go through it if we can together. The date is 8/9 of 17.
It looks like 10/9.
I'm sorry, 10/9 of 17.
Yes.
And the time of the code appears to be what?
21:56.
So, and obviously that's military time. Tell me what non-military time would be.
It's been a while. I believe that was 9:56.
And so we're talking night shift.
Yes.
And does it appear, based on the note over here, that as of this time of day, so at 9:56 at night, she is in the ICU?
Yes.
If you can, fair to say, Dr. Husel is the physician's signature down here on this code sheet.
Yes.
Talk me through at 21:56 what's happening on this code sheet.
At 21:56, looks like CPR was started. The patient was in PEA, or pulseless electrical activity. There was no pulse.
Okay, get a little volume.
1 milligram of epinephrine was administered. The patient was intubated and started on Levophed and vasopressin.
Okay, so let me walk you through this. This right here, the 1 milligram of epinephrine, that's to help someone live, right?
Correct.
And the same thing about them being intubated, right? That's a life-saving measure as well, is it not?
Correct.
And then it looks as if the levo, the vasopressors were increased. Is that a fair summary of what's over here?
Yes.
And then does it look like 2 minutes later, those life-saving measures, her heart rate actually drops? Would you agree with me on that?
Yes.
And then we've got 2 minutes later after that, her heart rate is still at that 68.
Yes.
And so what, if any, life-saving measures are done under the guidance of Dr. Husel at that time?
An additional dose of epinephrine.
And then it's hard to read this, but we can, fair to assume this last number is later in time?
Yes.
And it looks like from that epinephrine dose that her heart rate increases?
That's correct.
And what's this note over here, if you can decipher that?
The heart rate was picked up via a Doppler, which was a machine that we used with weak pulses, weak heart rates during code situations, and then the blood pressure was taken on the left arm.
So, and do you have any independent recollection of this event?
No.
When there's a physician signature on a code, fair to assume the physician is in the room calling the code.
Yes.
Is that right? Tell me visually, or tell the jurors more importantly, how that works. Code blue is called. Who's in the room?
A lot of people. Usually the physician, Dr. Husel, any nurses, respiratory therapist, pharmacist. Usually the family members are escorted out at that time, and all hands on deck situation essentially.
An all hands on deck situation, because fair to say everyone in the room knows that that person might die right then.
Yes.
Chaotic?
Can be.
And this last note right here, when it goes, this patient's heart rate goes to a 74, Doppler reads it, and a blood pressure is indicated on her left arm. She lives.
Correct.
And this moment, right, where her life is saved, is approximately 2200 on 10/19/17. Would you agree with me?
Yes.
And I want to take you back, 10/9, sorry. Take you back to State's Exhibit 3C. Later that night is when she passes.
Correct.
How many codes, if you recall, and an estimate was good, did you participate in with Dr. Husel during your time at Mount Carmel West?
A lot. I couldn't put a number on it.
And just because I'm a lawyer, I'm going to ask for a number generally. More than 20, less than 20, more than 50?
I would guess more than 50.
So more than 50 times in your time as either a response nurse or as an ICU nurse, you were in a room with Dr. Husel when he is coding patients and trying to save their lives.
Yes.
And saving their lives.
Yes.
I want to talk about patient Melissa Pennick. You were shown State's Exhibit 14G. Just want to confirm that your involvement with Ms. Pennick was not in the ICU. Is that correct?
Correct.
Okay. And so, given that it wasn't in the ICU, it had nothing to do with Dr. Husel.
In these situations, I oftentimes called the ICU, Dr. Husel included, to essentially put them on his radar, ask for his assistance or guidance at that time, and facilitate the transfer to the ICU. I would be with him the whole way.
And this is why, on direct, Ms. Sawyer said that you're good, because I was going to ask you a question about, did you sometimes call Dr. Husel before a patient even got to ICU and say, hey,
Is there a question here?
yes, hey, you called him at times, did you not, and say, patient's on the way, have a heads up for this patient?
Yes.
And there were times even before a patient got to the ICU where you might call him for advice or bounce a question off him as well. Is that correct?
Yes.
And when you would make those calls to him, fair to say that he was approachable,
Yes.
accessible,
Yes.
willing to take the time to listen to the question and answer it?
Yes.
You were asked about the shifts, 7 p.m. to 7 a.m. I know was your shift. As a matter of practice, when the shifts would change between the nurses, was there or wasn't there like a huddle where the night shift would talk to the day shift nurses and ensure there isn't a gap in care?
Are you talking general ICU?
Yes, general ICU.
Yes. We would get bedside report from the day shift nurse that cared for the patients that we were assigned that night.
And purpose, based on your experience, is so that despite the shift change happening, the patients continue to get constant care.
Correct.
And that was a part of those huddles or those, the exchange of information was a regular practice within the ICU, was it
Yes.
not? I know you were asked a lot of questions about what you consider to be an emergency. I noted that you indicated that as a rapid response nurse, kind of by definition, anytime you were called, it was an emergency.
Yes.
And part of your title as a rapid response nurse is rapid,
Yes.
right? So you come quickly.
Yes.
Overrides were a common thing within Mount Carmel West during your time there?
Yes.
I noted, in fact, that on your direct you indicated that they were very common.
Yes.
Speaking of overrides, though, I know that you've been interviewed by police in this case, correct?
Yes.
And I know at one point that you had a deposition. Isn't it true that you were asked the question about your practice or you using overrides in relation to Dr. Husel? Do you remember being asked about that?
Not exactly, but
Okay, let me ask this. Fair to say that any override that you ever entered into the system was not at the direction of Dr. Husel?
no.
That is fair to say?
Yes, that is fair to say. Sorry.
That's okay. I just want to make sure we're clear. As a nurse, nurse, rapid response or ICU, fair to say you rely on your school,
Yes.
other trained nurses that you're working with, your peers,
Yes.
your own personal experience,
Yes.
and the physicians that surround you.
Yes.
All of those things come into play when you're doing your job on a daily basis.
Yes. Oh, sorry.
There was just a question about the step-down ICU, and just to be clear, Dr. Husel did not work in the step-down ICU, is that correct?
Yes, he would.
Oh, he would work in the step-down?
Yes.
And what years was that, if you recall?
I don't remember the exact year it was initiated, but I would say that at least through 2017 to 2019, or 2018, I guess.
And the step-down at that time was on a different floor or same floor?
Different floor.
Got some questions, some general questions, if I can. Let's talk about patient-specific. And those are just two words used together. Fair to say that in your experience and training, you believe that every patient is different.
Yes.
And when you, as a nurse, are treating and caring for a patient, it's individualized.
Yes.
You have to look at a number of different factors when determining what is appropriate as to how to treat a patient.
Yes.
And, I'm sorry, I just have to speak.
Yes. Sorry.
And the same is true, how many palliative extubations have you been involved in your career?
It would be an estimate. I would guess over 50.
And palliative extubations at Mount Carmel West could occur during the day shift and also during the night shift. Is that true?
Yes.
And of the 50 approximate palliative extubations that you've been a part of, fair to say that those are also patient-specific in terms of what's appropriate with respect to dosages?
Yes.
And you've worked, obviously, in those situations with a number of doctors, ICU physicians.
Yes.
And wouldn't you agree with me that even physicians do things differently?
Yes.
In fact, I know that Dr. Husel was on the night shift with Dr. Hagris, and they did things differently, did they not?
Yes.
But at the time, you both found them both to be smart doctors.
Yes.
In these situations where you've been part of a palliative extubation, there's a discussion with the family.
Yes.
And at Mount Carmel West, isn't it true that oftentimes there's a chaplain that comes and is involved in the discussion?
Yes.
Going specifically back to the Ryan Hayes matter, there wasn't a family discussion with Dr. Husel with respect to Mr. Hayes because that decision had already been made on the day shift.
I believe so.
When you administered the order for Mr. Hayes, where was Dr. Husel?
He was assisting with Tyler Springer in the fresh admit from the emergency department.
Because there was another patient at that very moment that was in critical condition, was there not?
Yes.
And that's kind of part of this busy nature of the ICU, right? It could be one patient that you could lose and another patient you could be losing simultaneously.
Yes.
I forgot to ask you something about Beverly, if I could just go back to Ms. Schertzinger. One moment. Because I remember the questioning about there's the front side and the back side of ICU. Do you remember those questions?
Yes.
Just give me a second. testimony. Yes, that's where I'm going. One moment, sorry. Just going through my notes. You were asked these palliative extubations, 50 or so. Fair to say that sometimes they're not pretty.
Yes.
And I just need you to speak up a little bit. And in your experience in these palliative extubations, that patients can experience pain.
Yes.
And have you ever heard of the expression "a bad death"?
Objection, Your Honor.
I'll permit the answer. You ever heard that expression?
Yes.
And have you ever, in your experience as either a rapid response or an ICU nurse, seen a bad death?
Yes.
What does that describe that?
As in his experience.
In your experience as a nurse?
Any time where the patient that has been withdrawn on is experiencing discomfort, agonal breathing, air hunger, physical distress, is what I characterize as a bad death.
And in your experience as a nurse, throughout those years, there are a number of times when the family members are in the room. Is
Yes.
that right? And seeing that, the air hunger, right? And air hunger is gasping for air.
Objection, Your Honor.
Sustained. Let's ask the question, please.
Gasping for noise. Is that
Yes.
fair?
Okay. It was sustained. You got half of a question now. Ask the new question.
Okay. And obviously the family members are in the room should they choose to be during the extubation and after the patient is extubated.
Yes.
And when you've seen those bad deaths, and I'm not going to ask you to, of course, say any patient names, but do they stay with you?
Yes.
Where's the picture? No. One moment. I want to just talk to you about the nursing station. And then I will be done. One moment, please. Of course, it has to be the last photo. Showing you what's been marked as States Exhibit 15Z. This is a nursing station right here?
Yes. Oftentimes the pharmacist would use that computer as well.
Thank you. And does it appear, I'll zoom in a little bit, that there's actually 2 monitors there?
Yes.
Based on your experience and time at Mount Carmel West, would sometimes a nurse and or pharmacist sit there just if they weren't actively engaged in something else?
Yes.
And what does this room number look like here?
Room 9?
And this area right here, is this a traffic area? People would walk in and out from there?
Yes.
Just want to go back to, if we could, that code sheet I showed you with respect to patient Schertzinger. Joint Exhibit 3, page 118. The room number appears to be what for that patient?
Room 9?
So it's right there, right next to the nurse's station.
Yes.
And with respect to the nurse's station, if you recall, based on your experience as a nurse at Mount Carmel West, that if a patient is being palliative extubated in room 9, that I, as a nurse, could give the family some privacy and sit right here and monitor.
Yes.
And is that, in your experience, a practice that was done, that a nurse might leave and then monitor the situation from a terminal?
Yes, every room had a curtain that could be closed.
And was that a practice that you did?
Yes.
You did that. And tell us, when you're here during an extubation, what information you can see on the monitors as to what's going on in the room.
We still have access to heart rate, sometimes blood pressure from the nurse's station. At that time, the monitors are usually in the rooms, are usually put on standby so that the family don't incessantly watch it.
And when they're put on standby, fair to say that the noise is also turned down so it doesn't distract the family?
Correct.
But you have full capability during your experience to monitor the situation from a terminal.
Yes.
And that would be something that you would have done during a situation like that, is it not?
Yes.
One moment, Your Honor. Nothing further. Thank you.
Okay. I assume you got more than 10 minutes?
No, I don't think I do, Your Honor.
Okay. Then we'll sally forth.
Sorry, I'll reorganize them.
That's all right. I'll give you a hard time later. Mr. Rudman, where did you learn, or who taught you that agonal breathing is painful?
Nurses, charge nurses, physicians.
Okay. Are you aware of literature that says it's not painful?
I have seen that literature.
Okay. The code sheet, Diane, can I borrow that back from you? And I'm going to show you, this is Joint Exhibit 3, page 817. When there's a code going on, is this when you're using the code cart, the emergency cart?
Yes.
And epinephrine, the levophed, those would all be available on there.
Yes.
Would you ever use fentanyl in a code situation?
No.
Why?
We're trying to resuscitate a patient. That's not a medication used to resuscitate a patient.
What about midazolam?
No.
What about Versed?
No.
Why not those two?
Same reason.
Okay. And in regard specifically to Ms. Schertzinger, and I'm going to point your direct attention to 3C again, and your involvement. So in this note, you talk about that code that we just looked at. Is that accurate?
Yes.
At that time, well, first off, are you familiar with what a DNRCC and a DNRCCA is?
Yes.
What's a DNRCCA?
A DNRCCA is a code status that indicates that all life-saving measures will be applied up into cardiac arrest.
Okay. And a DNRCC?
Your Honor, I think it's beyond the scope.
Well, it goes to the medical records all permitted.
DNRCC is?
Comfort care.
Okay. So in this situation, as you're administering CPR, are either of those statuses in effect for Ms. Schertzinger?
From my note, I'm unsure. I would assume it would be arrest.
So because you're doing CPR, at the most it would be a DNRCCA?
Objection, Your Honor, leading.
It would be full code, excuse me.
Okay. So
Your Honor.
Okay.
Okay.
Overruled.
So it would be full code, which means you go ahead and do the CPR. At the time, and at that point, you wouldn't be looking at fentanyl, midazolam, or Versed.
No.
What about when the family decides to withdraw care? Would that be when one of those statuses go into effect?
Yes.
So at that point, would life-saving measures be used?
Life-saving, no.
Thank you. No further questions, Your Honor.
Okay. You may step down. Let's take our break, ladies and gentlemen. Just hang tight for a second. I'm going to get them in their break. I'll see you guys in 15 minutes.
All right.
Let's say 22. I'll give you 18 minutes. That way there's no flux to the bathroom. Very admonitions. I'll see you guys at 22.
Oh, and these are the ones that
back through that, of course. Mr.
Okay,
President.
go ahead. So let her get up. Ms. Sawyer, anything for the record?
No, Your Honor.
Ms. Menashe?
Thank
Ms.
you.
Menashe, anything for the record?
No.
Okay, we're on break. Record?
No, Your Honor.
Anything for the record?
No.
Okay. She's bringing the jury in. They do have fun in the hallway.
And I'm not ignoring you. Sometimes it takes a minute for me to realize what you say.
This,
Oh, he was talking.
I can't get it removed because it's special order and fitted.
Put it in storage.
I was just happy to get what I got.
Right. It's a big intro. All rise.
You guys have got your own order and everything. It's a team. You may be seated. As soon as everybody gets there. There we are. Ladies and gentlemen, I hope you had a wonderful break. We're going to continue on the testimony. Ms. Sawyer, you're going to call your next witness.
Thank you, Your Honor. State will call Tyler Springer to the stand.
Okay, so I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God? Yes. Okay, well, don't you go and have a seat there. Get yourself comfortable. You've got an aerial mic there in front of you. Okay, I need you to state your name and spell it for me so that my court reporter can get used to your diction.
Gotcha. Tyler Springer, Tyler Spr.
Hold on, I know you got a little bit more than that.
Tyler Matthew Springer. Oh, okay. Okay, Tyler Springer.
You gotta spell your middle name since you threw it out there.
Okay. TYLERMATTHEW SPRINGER.
Can you hear him okay, Madam Court Reporter?
Yes, sir.
Y'all hearing him?
Yeah.
Okay.
Thank you, Your Honor. Mr. Springer, did you attend college?
Yes, ma'am.
And where did you go to college at?
Mount Carmel College of Nursing.
And what degree did you receive?
Bachelor's of Science of Nursing.
And when did you receive that, sir?
2014, I believe.
And after that, did you become licensed as a nurse?
Yes, ma'am.
When did that happen?
2000, I think sometime in 2014, like the end of 2014.
Were you employed after you received your RN?
Yes.
Where was that at, sir?
Mount Carmel West ICU,
And how long were you employed at Mount Carmel West?
5 years.
Okay, from what date to what date?
I'm not sure the dates, but 2015 to 2019, I believe.
And why did you leave?
We were let go by Mount Carmel.
Okay. And at some point, did you have to appear before the nursing board because of incidents at Mount Carmel?
Yes.
And did anything happen?
Well, I didn't know. I did not have to appear in front of the nursing board. There was just an agreement with
Okay.
them.
And what was that agreement with the nursing board?
Objection, Your Honor.
I'll permit it.
Go ahead and answer.
1 year license suspension with 2 year probation.
And when did that license suspension occur?
On my birthday, November 18th of last year.
Do you
Or not last year, the year before that, sorry,
2020?
2020.
Okay. Do you currently have your license back?
Yes, ma'am.
And are you currently employed?
Yes.
And without saying where, what are you currently doing?
Pre-certification nursing, it's not anything that's directly patient care, more so just looking at clinical information.
Okay. Let's talk about your employment at Mount Carmel. You indicated that occurred sometime in 2015?
Yes.
And what were you doing at that time for Mount Carmel?
I was just an ICU registered nurse,
Okay. What were your job duties as an ICU nurse?
taking care of very sick patients that would come through.
And when you say taking care of, explain to us a little bit about what you would do in that position.
Based off of the situation that was occurring with the actual patients that came through, changing them, bathing them, doing whatever it is that they need as far as, if they need intubated or lined or anything like that, putting an A-line in or a large IV in the neck, things like that we would help assist with.
Okay, and you got a little bit of a low voice, so I'm going to remind you to speak up
Yep.
so everybody can hear. Did you work any particular shift as an ICU nurse?
In the beginning, I worked nights. It's more so generally, I would say if you're the low person on the totem pole, you don't really get to choose, but I started out on nights and then I ended up transitioning to days.
Do you remember approximately how long you were on the night shift?
I want to say in the beginning, it was probably the first year was all night shift, and then it started to kind of go back and forth. I'd work some days during the day, and then, if they needed help on nights, I would help pick up on nights or vice versa.
Okay. Fair to say throughout the time period you were at Mount Carmel, you still continued to work some night shifts then?
Yes.
We've heard a lot of testimony about obtaining medication and how nurses do that. Can you explain that to us also, what you would do in your experience?
You said with just obtaining medications?
Correct.
We would get it through the Pyxis machine usually, or it was sent up via like a tube with the tube station from the pharmacy itself.
Okay. Tell us what you would have to do to access medication via the Pyxis.
So there is, they would put in an order in which you could go and you could get it out, or sometimes they didn't necessarily have it in, but if you, and sorry, I'm trying to think here because it's been a while. If they put the order in, you could still override the medication, or you could still override it even if they didn't put the actual order in itself into the actual system. I forget the system that they use particularly, but it could either be scheduled and you can go and get it, or sometimes you could override it despite if there is an order that had been given by a particular doctor.
All right, so you said if they put the order in. Who is they?
The doctors.
Okay, and they put it into the electronic medical record? That's what we've been calling it.
Yes.
All right. How would you know then that you were to go get the medication?
Sometimes there's like an icon that would show like review orders or whatever it was, and it would just show like, hey, this medication needs to be given, or you could look at the MAR. I don't know what the meaning of that is, but
Okay.
you could look there to see what medications could be ordered.
Okay. And you said sometimes they put it in, sometimes they don't. Again, the doctors?
Yes.
So that would be what we've been terming a verbal order?
Yes.
Right. You also mentioned getting it via override. Explain to us what you mean by that.
So basically, you could go to the Pyxis machine, say you got a verbal order. You could go, and it actually happened all the time. We saw nurses do it all the time on day shift and on night shift.
Okay.
You could just go pick out whatever the medication it was that was ordered that you got a verbal for, and then you could withdraw it at that time from the Pyxis via override. You could just look up the medication.
What's the difference between pulling it via override and not pulling it via override?
I don't recall.
Okay, that's fair. And you had said earlier, I could pull it via override or I could wait for them to approve it. Who's them in that case?
It would be pharmacy would be the person that I think would sign off on the medication or whatever was ordered.
And if there's an override, has pharmacy signed off on that medication?
Not necessarily.
Okay. Now, what is your understanding of pharmacy's role if you pull medication through an override?
That I don't recall.
Okay, that's fair too. It's been a while.
Right. Yes, ma'am.
Describe to us what the ICU at Mount Carmel looked like as far as how it was set up.
I would say it was shaped like a U.
Okay.
U-shaped.
How many nursing stations, for example?
Altogether, I believe there was 4, I believe.
Okay. How many floors did the ICU at Mount Carmel West consist of?
1 at the time.
Okay, so when you were in there, was it 1 floor?
Yes.
And you mentioned the Pyxis machines. How many Pyxis machines?
3.
All right. Mr. Springer, I'm going to start by talking to you about some of the patients you were involved with that we are here for right now. So, and I'm going to start with Bellissari. Sure. Okay. I'm going to show you what's been marked for identification as State's Exhibit 1E. Can you tell us which patient we're talking about here today?
Joanne Bellissari.
And what was her admit date?
Admission date was April 22nd, 2015.
And what date was she discharged from the hospital?
May 10th, 2015.
All right, so I want to talk to you specifically about your involvement. And I'm going to start with a note that you made on May 4th of 2015, and I'm going to direct your attention right there at the top so it doesn't fall over on me, right? All right, can you tell us, is that your name up there at the top?
Yes, ma'am.
And what's the date and time of this order?
May 4th, 2015 at 4:18 in the morning.
What are you doing at this time with Ms. Bellissari?
Can I read this?
Sure.
Okay. So it looks like we are changing over the tube from one side to the other. Typically, we would do that during the early morning hours before shift change.
Okay, you said tube. What are we talking about when you say tube?
Endotracheal tube, the intubation tube that goes into the actual lungs down through the throat.
So is Ms. Bellissari on a ventilator at this point?
Yes.
Okay. And tell us about your involvement in changing the endotracheal tube at this point.
Basically, we're next to the patient, and we are changing it from left to right or right to left, whichever way it was.
Okay. Were there any issues that arose at this point?
Yes, so it appears that, from what I can read from here, that it looks like she became very agitated, biting down on the tube, so therefore she was more so awake, not going with the actual ventilator itself, being able to do its work, so therefore we weren't able to go from left to right, left to right. So therefore, she became agitated, and it looks like we ended up giving some medication to help calm her down.
Okay, what medication was administered?
It looks like fentanyl and Dilaudid.
Okay. And how much fentanyl was given at this point?
200 micrograms of fentanyl,
And how much Dilaudid?
1 milligram.
And that's, Dilaudid is what as far as the actual medication?
I guess I don't understand the question. I'm sorry.
Is that midazolam?
No, it is not. It's an opioid medication.
So that's hydromorphine.
Yes, hydromorphone, yes.
All right, so this is May 4th, 2015 at 4:18.
Yes.
All right, I'm going to direct your attention over to the page where we talk about the MAR, the medical administration record that you just talked about.
Okay.
All right, so middle of the page here. Would that be the 200 micrograms of fentanyl from that incident?
Not that I recall, no. 337. Yes.
Okay, and I note here you've got a pain score. What is the pain score you have at this point?
As an 8.
Okay, and then below that is the hydromorphone order,
Yes, ma'am.
and again, the pain score.
Is an 8.
And which doctor gave you these prescription orders?
Dr. Husel.
Did you administer those prescriptions?
Yes.
Did that resolve the issue with the pain score?
Not that I recall.
All right, what if I show you 5-4? Okay, I'm going to direct your attention at the top here.
Yes, it did resolve the pain, the pain and the agitation.
Okay, so after the 200 micrograms of fentanyl and the Dilaudid, what pain score does she now have?
0.
I don't have it. Sorry. Yes, ours both dates down. So at least with Miss Bellissari, that 200 micrograms appeared to relieve the pain.
Yes.
I'm next going to direct your attention to James Allen. And I've marked this for identification as State's Exhibit 8D. And can you tell us who the patient is in this case?
Yes, James Allen.
And what date was he admitted to the hospital?
May 24, 2018.
And what date was he discharged, sir?
May 28, 2018.
All right, and unfortunately, you're in the middle of the list here, so
Okay.
I'm going to direct your attention, and I'm going to show you the top first. What is this? Can you explain what this direct charting flow sheet is for us? What's that mean to you as the nurse?
It just looks like the oxygen delivery and the pain score charting that would be in our charting system that we used.
Okay, and explain to us, what do you as the nurse assigned to a patient have to do as far as charting for any patient that you're caring for?
Normal assessments, we would just go in and we would, chart what they look like, the physical exams, the pain scores, if they had IVs, things like that. Does that answer the question?
Sure, and approximately how often, if you're on the night shift, you come on at 7 p.m.?
Yeah.
Leave at 7 a.m.?
Yes, ma'am.
So during that time period, how often would you check on these patients approximately?
Every 2 hours.
Okay, so I'm going to direct your attention to the middle here, and do you see your name in there?
Yes, ma'am.
All right, there's a laser pointer in front of you.
Okay.
Can you use that to point that out to the jury where you're at?
Right there.
All right, so what date is this on, sir?
May 26, 2018.
And looks like you're charting every 2 hours like you just told us.
Yep.
And what was the pain score that you gave Mr. Allen during your time period of involvement?
0.
What does that mean to us?
Well, more importantly, what does it mean to him?
All right, what does it mean to you, sir? Is he in any pain?
No.
Okay. And I see the words here, nasal cannula. Am I
Yes.
saying that correctly? What is
Yeah.
that?
It's just It's a tube that goes into your nose, has little prongs, and it provides oxygen to the patient.
So at this point, Mr. Allen's not on a ventilator?
Correct.
All right, and then I'm going to direct your attention to the bottom of this same document. Let me show you this top level. What are you looking for in charting at this time?
Pain intensity scale, is pain level acceptable?
All right, I'm going to direct your attention to the very bottom. Is that you?
Yes.
And what is your finding regarding the acceptability of pain?
That they are having pain, yes.
Well, let me go back to the top.
Is pain level acceptable? Sorry. Yes.
Okay. Yeah, it's a little hard when the top
Sorry.
cuts it off, doesn't
Yeah,
it?
Sorry.
All right, and then going to the next page again, same thing as pain level acceptable. And is that again you at the top?
Yes, ma'am.
And your finding
Yes.
that it's acceptable?
Yes.
All right, and I want to just point out here, it's a reference to CPOT. What is that, sir?
That I don't know.
Okay.
It looks like it's a pain scale, pain intensity scale, but I don't recall. It's just been a long time, but I don't recall what tool
Okay.
or scale I guess we would use.
All right. Well, and let's go back just a minute. What type of training, when you started working at Mount Carmel, what type of training did you receive?
A lot.
Tell us about that.
It was just, there was a checklist. I can't recall everything. But basically, if there was a pain score, I was taught that there was a pain score of 0 to 10.
Okay. And then was there any when you first started, set orientation or training that you had to go through at that time?
Yes.
Tell us about that a little bit.
You had a preceptor that you would follow around. I do recall that I had multiple ones. It wasn't just one. I know that they tried to keep you with the same person, but I do recall when I was there was multiple nurses that I followed that precepted me per se. Taking care of different types of patients. They tried to do more so along the lines of cardiac patients, stroke patients, palliative patients, just different types of patients, and helping assist with putting an arterial line in or a large IV in the neck, or I don't know. There was a lot.
Okay. Was it a kind of sit down and you learn things, or did you learn on the job?
Learn on the job.
All right, so redirecting your attention back to Mr. Allen, and I'm going to talk Glasgow coma score. What's that mean to you?
I do not recall.
But that was something you used at Mount Carmel at the time?
From this, yes, it looks like it, yes.
All right, I'm going to... Do you see your name on here?
Yes, ma'am.
Can you point that out to us?
Yep. Right there.
All right, and what score was given?
14.
And then again with Mr. Allen, Richmond Agitation Scale, known as the RAS, I think.
Okay.
Do you remember that?
I do not recall.
But again,
It's just
something
been a
you
long
would have
time.
used during that time period?
Yes, I believe so.
All right, and I'm going to direct your attention to about the middle. Do you see your name on here?
Yes, ma'am.
All right, and can you point that out to us?
Yes. Right there.
All right, and it says C below T623, and it goes down to T770. Do you know what that means?
No idea.
All right. So I'm going to direct your attention. All right, and I see here at the bottom a T77 connected to the Richmond Agitation Scale, and that was the last number on yours. Do you remember that?
Yes.
All right.
I just saw yes.
What do you have here as the Richmond Agitation Scale?
Looks like drowsy, -1, not fully alert, but has sustained awakening.
Okay. And at least at the time you were doing this at Mount Carmel, you had been trained on that scale.
I do not recall.
Okay. All right, Mr. Springer, I'm going to direct your attention to State's Exhibit 2F. And what patient is this regarding?
Ryan Hayes?
And do you remember Ryan Hayes?
Yes.
Why do you remember him specifically?
Basically because it was probably the highest, amount of medication that I've given to someone. But also with the rise of all this, it's more so just been brought to my attention.
Okay. This was probably the patient you got disciplined for, or at least put on administrative leave
Your
for?
Honor, he's already answered the question.
I'll sustain. Let's move on.
What date was Ryan Hayes admitted to the hospital, sir?
April 2nd, 2017.
And what date was he discharged?
April 4th, 2017.
All right. All right. Mr. Springer, I'm going to direct your attention to the pain score area. Do you see your name on this?
Yes, ma'am.
Can you point that out to us?
Yep. Right there.
All right, so this would be on April 2nd, 2017?
Yes.
Night shift?
Day shift.
Day shift, all right.
Night shift, sorry.
Okay. What pain score on April 2nd of 2017 in the night going into April 3rd in the early morning did you assign to Mr. Hayes?
0.
And then I'm going to direct your attention a little bit further down. Do you see your name on here?
Yes.
Can you point to it again for us?
Right there.
And what about a little further up?
Oh, there. 0.
Okay, and keep going down. Where's the next time you see you?
Right there.
Okay, what date is that on, sir?
4/3/2017.
At what time? I'm okay if you just say that.
1922.
There you go. And what other time?
2110. Yeah, 2110.
What pain score did you give Mr. Hayes at this time?
0.
Do you remember what 0 meant as far as a pain score?
Just no signs of pain.
Do you remember Mr. Hayes' condition at the time you were treating him?
I do. Is it more so like what brought him in, what
Okay.
came to the ICU? Is that to answer your question?
Yes. What do you remember about him?
I know that he was a full arrest. Came in through the ER. Was found down. I think he was found down for about 10 minutes. He was in a bathtub, and basically they did multiple rounds of CPR, ACLS, to get him back to the hospital, or get him to the hospital, and then at the time he was transferred to the ICU somehow. I don't believe that I admitted him, but I know that he was intubated and on multiple medications, drip IV medications per se, if that answers your question.
Okay. Was he on any pain medication during the time period he had 0 pain scores?
I don't recall.
Okay. All right, I'm going to direct your attention to level of consciousness, CAM. What does this mean to us?
I don't recall what the CAM is, but if it's dealing with the level of consciousness, it's just seeing what their level of consciousness is, if that answers your question.
Sure. Do you see yourself on these?
Yes, I do.
Can you point those out to us?
Yeah, right there.
Okay, and what date is that on, sir?
April 2nd, 2017.
And what do you note as far as his level of consciousness for Mr. Hayes?
It's charted as comatose.
Okay. And do you see yourself on here anywhere else?
Yes.
And where is that, sir?
Right here.
What date is that on?
April 3rd, 2017.
And what is his level of consciousness at this point?
Comatose.
All right. Going to direct your attention to another page where it talks about cough reflex and gag reflex. What is that? What are you looking for with these two?
Their cough reflex or gag reflex.
Okay. Why is this important?
I mean, it's been a long time. I don't really recall.
Okay. Do you see your name on there, sir?
Yes.
And where is that? Can you point that out to us?
Yes, it is. Right here.
Okay, and what date is that?
April 2nd, 2017.
What did you find regarding the cough reflex
It was absent.
and the gag reflex?
It was absent.
And anywhere else that you see your name?
Yes, right there.
And what date is that?
April 3rd, 2017
And what do you find regarding the cough reflex
is absent.
and the gag reflex?
Absent.
Okay, do you remember a order for palliative withdrawal, palliative extubation of Mr. Hayes that occurred on April 3rd, 2017?
I recall that we were waiting for the son to arrive to make the decision for a palliative withdrawal.
Okay. What was your role regarding this palliative extubation?
The nurse that would potentially, if I was there when when the son was to arrive, to help with the palliative withdrawal. Nurses helped all the time, day and night, different patients.
Okay. Do you remember Troy Rudman coming up to assist with this?
Yes.
Tell us about that.
I do know that I recall that night, obviously we were waiting for the son to get there. I believe he arrived and made the decision to extubate palliative withdrawal. And I was getting another patient in the room, a couple rooms down, I think. It was a full arrest. And I think that if I recall, he wanted to withdraw, and Troy was there to assist while I was to get my other patient kind of settled in and to get it to where they were stabilized to where I could get back into the room.
Okay. And did you get back into Mr. Hayes' room?
Yes.
And at that point, did you receive a request for a medication order that you filled?
Yes.
And what date and time did this occur at?
April 3rd, 2017.
And who gave you the order?
Dr. Husel.
And I'm going to turn the page and direct your attention to the middle of the page here. How much fentanyl were you ordered to?
1,000 micrograms.
Do you recall how many vials of fentanyl that would be?
If I recall, 10.
Okay. And any other medication that you were ordered to draw at this time?
Looks like hydromorphone and midazolam.
All right. Hydromorphone being the Dilaudid we've talked about before.
Yes, ma'am.
How many milligrams of Dilaudid?
10 milligrams.
And you said midazolam, how many milligrams of midazolam?
10 milligrams.
And again, what date and time were those two?
April 3rd, 2017 at 23:16.
So the fentanyl, the Dilaudid, and the Versed all together for Mr. Hayes?
Yes.
Are you aware of whether or not Mr. Rudman had administered those exact same doses to Mr. Hayes about 20 minutes earlier?
I was not.
What did you do at this point? You were given these orders.
I would draw the medication up and go and give the medication to the patient.
Okay, so you withdraw from where?
From the Pyxis.
And do you remember whether you awaited for approval from the pharmacy or did this via an override?
Override.
And then once you withdrew this medication, what did you do?
I went to my room, obviously got the verbal order. We put the order in. Actually, we put the order in, overrode, and then I got the medication out and went and administered to the patient.
To Mr. Hayes?
Yes.
Was Mr. Hayes already extubated at this time?
Yes.
So that was done prior to you arriving in the room?
Yes.
Was there any family there at that point?
I believe the son was there.
and you said you got the order. Who did you get the order from?
Dr. Husel.
All right, and Mr. Springer, I'm going to direct your attention back to, this is again 2F, patient records for Ryan Hayes, and this is the pain intensity score. Now, did you enter a pain intensity score at this time when you administered the 1,000 micrograms of fentanyl, the 10 milligrams of hydromorphone, and the 10 milligrams of Versed?
Yes.
What pain score did you give Mr. Hayes?
A 10.
What did you base that on?
I anticipated that he had pain. I know that he was turning blue. Also, you have to think, too, that with the compressions that he had and the healing process, he's probably going to have some pain with that as well.
Okay. Now, you said compressions from the CPR?
Yes, ma'am.
That he had before he even got to the hospital.
Yes.
But what pain score did you give him before that?
A 0.
Okay.
0.
Thank you. I have no further questions, Your Honor. Diane?
Bias? Or Mr. Nash, I'm sorry. I thought Mr. Bias was up. My fault.
You know, sometimes we mix it up.
They're right there, Diane.
Thank you. Repeat it. Paula?
Yeah.
I am going to show the second page of the score chart.
Okay.
It's on Alan that takes it to the other scores.
Sure. Okay. Did he do those?
No, but I'm going to show it.
I may object to that.
Okay.
Must be passed. Okay.
Good afternoon.
Hi.
Diane Menashe. Good morning. Good morning. Diane Menashe on behalf of Dr. Husel. Diane Marie Menashe.
Yeah, right.
I haven't said Marie in a long time.
Spelling it.
Want to go back through some of the things that you testified to, and I'll start with Mr. Hayes, the last patient that you just talked about. Do you remember you were interviewed by Columbus Police Department in this at some point with respect to this patient? Is that correct?
Correct. Yes.
And fair to say that that was in December of 2018,
Yes.
specifically December 7th of 2018. Does that sound right?
Yes.
And in that interview, you had indicated that there was kind of a hesitancy or hold with respect to Mr. Hayes, had you not, because the day shift had called the son and everyone was waiting for the son to arrive.
Yes.
And the son, as you indicated and recall, was he not the next of kin or power of attorney for Ryan Hayes?
Yes, ma'am.
And you indicated to police, correct, that the son was coming from North Carolina?
Yes.
And so that's 6-7-ish hours from Columbus, Ohio. Would that be fair to say?
Fair to say.
And in that process, it's actually the hospital that called the son. Is that how you recall it?
I don't recall how I know that I didn't call, but I don't recall who actually called the son.
That was my next question. You weren't the one that called.
Correct.
But there is a pause waiting for the son to arrive.
Correct.
And the pause lingers into or goes into the night shift. Is that correct?
Yes.
And ultimately the son arrives.
Yes.
Without going into what was said, fair to say that there was a lot of tension between the patient and the son.
Yes.
There was, when the son arrived, it was not a warm feeling that he exhibited, in your opinion, with respect to his father. Is that fair to say?
Yes.
And I asked this to determine what you did based on what was said, but isn't it true that when the son arrived, he said, pull the plug?
Yes.
And then that indicated And then the medication orders were placed for the palliative extubation.
That I recall, yes. Well, it would have been, yes, we would have been told to actually palliative extubate, yes.
And ultimately, as the next of kin or power of attorney, if you know based on your experience that he was the one that, he, the son, was the one that had to make that final decision.
Yes, ma'am.
I want to talk about, we'll go through the Ryan Hayes records. Showing you what's been marked as State's Exhibit 2F. I remember in your December of 2018 interview, you said, did you not, that you had done a significant number of palliative withdrawals?
Yes.
I think you indicated thousands, but how many had you done as of 2018, just in your course of your career?
I don't recall the number, but I know that I had done multiple.
Okay. And so Mr. Hayes was not your first palliative extubation?
No, ma'am.
Showing you what's been marked as State's Exhibit 2F, and just to orient ourselves, fair to say this looks like the medical records you were shown for Ryan Hayes.
Yes, ma'am.
Just want to go through them if we could. With respect to, I'll just go right to the direct charting flow sheet. You were asked questions about your indication here on 4-2 that the pain score was 0. Do you see that?
Yes, ma'am.
Right. And fair to say that 4-2 was the day that Mr. Hayes had arrived in a code situation as an overdose.
Yes.
And you talked about on your direct that when you were trained at Mount Carmel, you had extensive training. Do you remember that testimony?
Yes.
And fair is it not that you were trained that at Mount Carmel that the pain score was 0 to 10?
Yes.
Based on your training at Mount Carmel West as a nurse, fair to say 10 was the highest level of pain.
Yes.
And in your experience as a nurse, if you recall, were there times when you rated pain a 2?
Not that I recall, but...
Okay. What about a 5?
Not that I recall, but potentially yes.
Okay. There's other numbers in between 0 and 10.
Yes.
That's my point.
Yes.
And I will get to you and other numbers in a second. But you indicate a 0 here on 4-2 on the day that Mr. Hayes comes into the hospital. Would you agree with me on that?
Yes.
And then down here on 4-3, you indicate 10 in 2 places at 23:16.
Yes.
Do you see the time there?
Yes, 23:16, yes.
Okay. And I think the point was made 0 to 10, but you would agree with me that more than 24 hours has passed between those differing pain scores?
Yes.
One moment, Your Honor, just ask for some. I want to go now to the fentanyl order that you were asked about on 4-3. Do you remember that line of questioning?
Yes.
And showing you here, I'm assuming that you had an opportunity to review the MAR record for Ryan Hayes in advance of your testimony today?
Yes.
And so it looks as if it does it not that Troy Rudman placed an order for fentanyl of 1,000 micrograms, and the time on that is 22:57?
Yes, ma'am.
And then I want to go down here to where it indicates fentanyl order is, it indicates that your name is by that. Is that correct?
Yes, ma'am.
Okay. And what time does that appear to have been done?
2316.
Okay, so how much time approximately was that after the order by Nurse Rudman was placed?
15 to 20 minutes.
Talk to us about, fair to say, pain as a matter of practice with respect to nurses is checked sometimes on a 15-minute interval. Is that fair to say?
It depends. It could depend on the patient's family. You know, you're checking more often, more frequently if they think that the patient's in pain, or Troy helped with palliative extubating. I wanted to go check on my patient to make sure, check on family, check on my patient, see how he was doing, per se, if that answers your question.
It does, because I remember in your interview with the police, you said, did you not, and I think you said, did you not, that you can't stress enough that your entire life, right, in your heart and with respect to your family, you've never wanted to harm anyone.
No.
And that was true on 4/4 of 2017, was it not?
True.
You wanted to provide comfort to Mr. Hayes.
Oh, absolutely.
And with that intent of providing comfort to Mr. Hayes, you put in this order for 1,000 micrograms of fentanyl. Would you agree with me on that?
Yes.
And you also spoke of the other order that you entered as well, in addition to the fentanyl.
Yes.
The question was asked if you had known about the administration of the previous 1,000.
No, I did not.
And you indicated you had not.
No, I had not. I do not recall it.
I want to go here and here. When you entered this order in, and you would agree with me that this is your name here.
Yes, ma'am.
That the pain scores indicated is 10.
Yes.
And that is after, in hindsight, we know that 1,000 micrograms of fentanyl was given.
I don't know how much was given, but I do know that, and I don't know if any medications were given at all. I don't recall any medications being given at all, but I do know that Troy had extubated him, and then I went, after I got my other patient, and checked on the patient, or Mr. Hayes.
So then this is, I think, maybe a more fair question. What we know is that when you arrived on scene, and when you placed this order, you indicated that the pain score was a 10.
Yes, ma'am.
And then again, when you placed the Dilaudid order for 10 milligrams, you also indicated there, did you not, that the pain score was 10?
Yes, ma'am.
So at 23:16, pain score 10 for patient Ryan Hayes.
Yes.
Fair to say that at any point in time during your career, you wouldn't have input a 10 unless you believed at the moment it was a 10.
Yes.
Just need to speak up for the quote.
Well, yes.
I want to go to now talk about patient Joanne Bellissari, showing you what's been marked as State's Exhibit 1E. Does that seem to indicate that those are the records you were shown with respect to Ms. Bellissari?
Yes, ma'am.
I just note this so we can see it, but fair to say down here, this appears to be a pain response form from you, does it not?
Yes, ma'am.
And I just note that there are occasions when you note that the pain has been relieved from medication, do you not?
I'm sorry. Can you repeat the question?
Sure. There are times, as indicated by this medical record, when you note that pain has been relieved from the medication.
Yes.
You were asked specifically about this event on 5/4 of 2015.
Yes.
I want to scroll down because I don't expect you to memorize it. Ms. Bellissari came to Mount Carmel West on 4/22,
Yes.
and her discharge date or date of passing, as we now know it, is 5/10.
Yes.
5/4 is kind of, it's in the middle a bit, right? It's 6 days from when she passed.
Yes.
So I want to focus on this because this 200 micrograms of fentanyl was an order placed by Dr. Husel.
That I don't recall.
Okay.
Yeah, it doesn't show it.
Okay, and that was your testimony on direct.
Oh, yes. Yes.
Okay.
Yeah.
But I'm happy to show you.
There's a lot. Sorry.
Don't be sorry. I'll go here if we could. Dr. William Husel. Does that look familiar?
Yes.
Okay. And here's why I just want to ask about this, because the number, it was 200, was it not?
Yes.
And a milligram of Dilaudid. This man right here.
Yes.
And you were asked whether it actually relieved the pain or not. Remember those lines of questioning on direct?
Yes.
I just want to walk through the note together if we could. Patient became very agitated in changing the tube.
Yes.
Because changing the tube, that's the trach tube, is it not?
Yes, ma'am.
Can be painful.
Yes.
And you have seen that in your experience as a nurse.
Yes, I can recall multiple times where we would change. It's very uncomfortable, I would say.
And so to provide comfort to that patient, in your capacity as a nurse, an order of 200 micrograms of fentanyl and 1 milligram of Dilaudid was ordered by Dr. William Husel.
Yes.
You weren't asked about it, but would you agree that the note goes on to say, even with 200 and 1 milligram of Dilaudid, what does that next sentence say?
Still unable to change tube from right to left. Tube left on right side due to patient biting down on the tube.
And you would agree with me not, based on your experience as an ICU nurse, that patient biting down on the tube could be an expression or indication of pain?
Potentially.
Or discomfort.
Yes.
And that's after the 200 micrograms was given.
Right.
And notably, this event right here is when Miss Bellissari was on a ventilator.
Yes.
Not when she's been extubated.
Correct.
And you know what? Sometimes there's a method to my questioning. One moment while I pull this record up. The pages aren't numbered, Your Honor. No, I'm just explaining my delay. I'll just show it to you.
I need this right here. No, just give me a second here.
One moment, Your Honor. I want to find this. I had asked you earlier if you'd ever used numbers other than 1 and 10. Do you remember that?
Sure. Yes.
Directing your attention to this 200 micrograms of fentanyl that was ordered by Dr. William Husel. Does that look familiar to you?
Yes.
I just note here, your order,
Yes.
you performed the administration of this medication?
Yes, ma'am.
And the pain score that you've indicated right there is what?
Is an 8.
Okay, let me go back, if I can, to Mr. Ryan Hayes.
Okay.
also showing you what has previously been marked as State's Exhibit 2F. Also, just want to make sure, and I left this out, this is Mr. Hayes' MAR. Do you agree with me on that?
Yes.
Okay. And down here, where the fentanyl order was placed with respect to the 1,000 that you administered, would you also agree with me that the indication you've noted is pain relieved with medication, and you noted no?
Yes.
So that's separate and apart, is it not, that entry point from the 10 as a pain score?
Say that again, I'm sorry.
Pain score 10?
Yep.
You input that?
Yep.
And separate question, pain relieved with medication?
It says no.
Then going on, does it not, with respect to the MAR, it indicates that pain relieved with medication is continued to be no.
It says no, yes.
And then we've got the pain score 10 on the heels of the pain relieved with medication.
Yes.
Okay. I want to talk now about Mr. Allen. Showing you what's been marked as State's Exhibit 8D. Does that appear to be the record of James Allen that you were shown on direct?
Yes.
Just want to go through some of the questions that you were asked about. And I just want to orient you, if it's okay. Showing you page 1, you were asked questions with respect to pain scales that you gave on this sheet. Would you agree with me on that?
Yes.
If I can flip to the next page, fair to say that based on the medical record...
Your Honor, I'm going to object. He's not anywhere in that area, and he's not after it, so it's not something he would have been able to even review in the course of his job.
Okay, so...
Let's rephrase.
When these pain scales are entered, Mr. Allen is not on a ventilator, is he?
No.
So, in your experience and training as an ICU nurse, a patient's condition can change drastically in the ICU, even between minutes, right?
Yes, ma'am.
And hours.
Yes, ma'am.
And days.
Yes, ma'am.
And when someone's on a ventilator, things can really change.
Oh, yeah, yes.
And that's with respect to pain, comfort, discomfort, all those things.
Yes, ma'am.
So I ask you, because you were asked on direct examination about the Glasgow coma score that you indicated right here on 526. Do you see that?
Yes.
Okay. But we know that Mr. Allen lived until 528.
Yes.
And fair to say that he was not on a ventilator on 526.
Yes, he was not.
And so would it surprise you, or would it be unusual based on your training and experience as an ICU nurse, that someone's Glasgow score could go down over the course of an hour, 2 days, or 24 hours?
I don't recall the Glasgow coma scale or Glasgow coma score, but I would say yes.
And isn't that kind of the point of charting periodically, is because in the ICU, things can change quickly?
Yes.
Experience as an ICU nurse at Mount Carmel West working the night shift. Do you recall an estimated number of times that you were in code situations with Dr. Husel?
I don't recall, but I mean, I worked. Him and Hagris, I think, switched off on and off certain days, so it just depends. But I can't recall.
Are code something unusual or not unusual in the ICU?
I would say that they are usual. They can happen.
And because I think on direct you indicated that people in the ICU are very sick people.
Yes, ma'am.
And a code situation takes place when someone is actively dying.
Yes. Yes, ma'am.
And if a person comes out of code, then essentially their life has been saved.
Yes.
Would you agree with me that during your time as a nurse at Mount Carmel West, as an ICU nurse, that when determining whether an order was appropriate, you relied on your education? Correct?
Yeah.
Your prior experience?
Yes.
Input or experiences with your peers, your fellow nurses?
Yes.
And also input and time spent with physicians that work with you.
Yes, ma'am.
You relied cumulatively on all those things when you were determining whether a dose or patient care was appropriate.
Yes.
And just so we're clear with respect to the Ryan Hayes order of 1,000 micrograms of fentanyl, you administered that order.
Yes, ma'am.
And you're certainly aware of voice reports within the hospital.
Vaguely.
Like if there was a problem, could you report a problem within the hospital, if you recall?
Yes.
And when you gave that 1,000 or administered that 1,000, we know from the records that you indicated that the patient's pain score was a 10.
Yes, ma'am.
I can assume, would you agree with me that during your time as an ICU nurse, you had the opportunity to work with a number of different critical care physicians?
Yes, ma'am.
And even just Dr. Husel and Dr. Hagris, would you agree with me that even physicians that are similarly titled and trained do things differently?
Yes, ma'am.
And that was true of Dr. Hagris and Dr. Husel, was it not?
Absolutely.
I know you were asked about it, but two more points. The nursing station, as you recall, there was more than one on the ICU floor?
Yes, ma'am.
And during a palliative extubation and the extubations that you participated in, were there times when you would leave the room to allow the family to have time with their loved one?
Yes.
And when you did that, where generally, in your experience, would you go?
We would go to either the nursing station, or we would go look. If we had to go look at our other patients, we'd go and we'd proceed for assessing our other patient.
And fair to say, if you're at the nursing station, there are monitors there which allow you to continue to see what's going on in the room.
Yes, ma'am.
And while the machines visually and auditorily are shut off in the room, the patient's still being monitored even after they're extubated, right?
Yes, ma'am.
And that's information that you would continue to have access to as a nurse.
Yes, ma'am.
You were asked about the code changes. I think you were asked about the DNR CC.
Yes.
And DNR CC. Do you remember that?
Yes.
And DNR CC, the CC stands for comfort care.
Yes.
Correct?
Yes.
And in your experience, you talked about 50-ish palliative extubations.
Yeah.
At that point, when the family or next of kin makes a decision to palliatively extubate their family member or loved one, the focus is on comfort, is it not?
Absolutely.
I just want to go lastly to Dr. Husel. Just in your experience with him over the years when you were at Mount Carmel, he was nice?
Absolutely.
seemed very smart to you,
Yes.
approachable,
Oh, yes.
accessible,
Yes.
kind of person, if you had an issue, you could go to him,
Absolutely.
and he was receptive to change,
Yes.
and you told the police that, didn't you?
Yes.
And he was even someone that you had a professional relationship with?
Yes.
Yes, and you had a good relationship overall, did you not?
Yes.
Nothing further, Your Honor. Thank you.
Thank you, Your Honor. Mr. Springer, let's go back to Mr. Allen, or Mr. Hayes, okay? And again, this is State's Exhibit 2F. Ryan Hayes? All right, and on cross, you were asked about the pain score of 0 on April 2nd, 2017. Do you remember that?
Yes.
And that was 24 hours before he...
Yes.
Let's talk about the pain scores down here. What date were those on?
4/3/2017.
What time?
22:57 and 23:16 or 23:16.
Well, nope, let's go above.
Sorry.
That's okay. That's when you did the 10, correct? The
Yeah.
2316?
It's at 17:40. Oh, jeez. Sorry, I'm like...
No, that's okay. 1749. It's
19,
okay.
21, 21, 21, 22, 59, 118, and 5:36.
All right. So April 3rd, 2110 is about 2 hours before. Would you agree?
Correct.
And you had a 0.
Yes. Sorry.
And that pain score of 10 was when the palliative extubation was occurring?
Not mine. Looks like when Troy did it, I'm assuming that's when it was going on, but mine had already passed. The extubation had already been performed.
Right. And on direct, you indicated that 10 was anticipatory when you entered it.
Yes, ma'am.
Ms. Bellissari, State's Exhibit 1E. Ms. Bellissari?
Yes, ma'am.
And going back to the note that was on cross-examination, she's intubated at this time?
Yes, ma'am.
On a ventilator?
Yes, ma'am.
And that, you indicated that her pain was relieved with that medication.
Yes.
Now, Miss, you were asked on cross-examination regarding the biting down on, if you had observed any pain in her, would you have gone to the doctor for more pain medication?
I would say yes.
When you say anticipatory pain, what do you mean by that, Mr. Springer?
Just because, a person, say, doesn't, how can I phrase it? Just because they may not show signs, you would assume, or you wouldn't, if they can't say anything to you, you can still anticipate that they're still going to have pain based off of what has happened to them. Color changes, things like that.
So this is something you're foreseeing could happen?
Yes.
Okay. Thank you. No further questions, Your Honor.
Your Honor.
And actually,
Thank you.
on the anticipatory.
I do, thank you.
Could I have the exhibit, please?
Oh, sorry, that's all right.
Based on that line of questioning, you would agree that anticipatory means you're anticipating something that will happen in the future.
Well, I'm anticipating at the time that something is, I guess, happening, if that answers your question.
It does. I just want to make sure, though, that we have the timeline correct. Right here, where you've entered the pain score as 10, it's 2316, is it not?
Yes.
On 4/3 of 2017.
Yes.
And then I want to go now to the MAR. Or I'll go rather to the order sheet. And fair to say that this is your name right here?
Yes, ma'am.
And the time here is 23:15.
Okay, yes.
So the order predates your entry that the pain was 10.
Yes.
Okay, so to say it was anticipatory, it actually is entered after the order for the medication, correct?
Say that again, sorry.
2315 comes before 2316.
Yes.
Okay. Nothing further. Thank you.
You may step down.
Thank you.
Why don't we take an early lunch since it doesn't make sense to start somebody in 5 minutes? Let's come back at 1:20. Okay? Does that give you guys enough time to nourish yourself? Okay. All right. Remember the admonition, we'll see you at 1:20.
Oh, here. You know what? Let's put it over.
prior to November 13th of 2018, approximately how many shifts you had actually worked in the ICU prior to that date?
Maybe maximum 6 shifts. When I had got off orientation, they were mandating nurses which means they don't need you stay home, and it rotates. And then I was also working on the step down unit, like 1 day a week.
All right. So you think maybe 6 shifts total experience, like on your own, prior to November of 2018?
Correct.
And do you recall what doctors you would have worked with at night during those approximate 6 shifts?
Dr. Husel or Dr. Hagris.
All right. And you talked about how nurses are the ones training you to work in the ICU. Do the doctors train you or give you explanations?
They will, yeah, they would.
What about Dr. Husel? Was he willing to train you and explain things to you?
Yes, he was. He would sit down with nursing students, nurses. He liked to teach.
So this is where you and your other nurses are learning how to do things at Mount Carmel West.
Objection to leading.
It's transitional committee.
Correct, from the staff, the rest of the staff.
What did they teach at Johns Hopkins regarding pharmacology?
I had one course in pharmacology, so it was like all drugs in one semester.
All right. Are other nurses and Dr. Husel and other doctors teaching you on the job about pharmacology then?
Correct, yes.
Okay. So, let's take you to the evening of November 13th, 2018. Do you recall that evening?
Yes.
Do you recall having contact with the family and the patient by the name of Sandra Castle?
Yes.
All right. Do you recall what time you got to work that night?
Somewhere probably before 7 o'clock, but my shift started at 7 p.m.
All right. So just looking back in your mind here, walk the ladies and gentlemen of the jury, you walk in at 7 o'clock, what happens?
So normally somewhere between 7 to 7:30 approximately, you'd get report from the previous shift nurse. So you do report with that nurse, so they kind of tell you what has happened, kind of pertinent information.
Okay. What happens next?
And then we went into the patient's room.
Are you referring to Sandra Castle?
Correct.
What, if any, information was relayed to you for purposes of what you did regarding Sandra Castle?
I don't remember all the details of what the previous nurse had told me. I know she told me generally what the patient came in for and how they had palliatively extubated this patient in the afternoon.
I'm sorry.
It was in the afternoon.
Okay, so previous that day in the afternoon?
Correct.
Do you recall approximately how many hours before she had been, because it's 7 now, and you say the afternoon, do you recall approximately, what was your understanding of how long she had been extubated?
I believe it was like a couple hours.
Okay. What, if anything, did this nurse tell you about her condition during this, I think this has been called a huddle? Is that what, am I using the right word there?
Correct.
During this huddle.
Can you restate the question again? Sorry.
Regarding her physical condition, was it relayed to you that she's in extreme pain, she's in extreme discomfort at this point during this handoff?
It was relayed to me that she was in pain, that they had ordered 10 milligrams of morphine for her.
And do you recall if that was a 1 dose or a PRN dose?
It was a PRN.
And what does that mean to you?
As needed.
All right, and they had been doing this for several hours at this point?
Correct.
And when you saw your patient, when you first got on, describe her condition to the ladies and gentlemen of the jury.
When I first got on, I mean, she wasn't like responsive, she wasn't talking, but she was kind of a little stiff, like grimace, like tense, grimacing. That kind of got worse as the night went on. She was labored breathing.
Okay. Would you describe her pain on the morphine that she had been receiving as the most extreme pain she could be in, 10 out of 10, at that point when you first got on?
Yes.
All right, so what did you do with that?
I mean, I had given her a couple doses of the morphine, but it seemed like as the night went on that it wasn't helping her
Okay.
anymore.
So you continued with this 10 milligrams of morphine every redosing has needed every 15 minutes.
Correct.
And she seems to be getting progressively
Worse,
okay.
more in pain.
Can you describe who's there with her?
When I originally came on shift, she had a lot of family. I don't know all of the family members, but there was a lot of family in the room. And as the night went on, they all said their goodbyes, and it was just a son and a granddaughter that were at the bedside.
Okay. Are you assigned other patients this evening, or are you just with Ms. Castle and her family?
I did have one other patient.
Are you going back and forth?
Yes.
All right. At some point, are you told by the doctor in the ICU about medication?
Which,
At some point, is Dr. Husel called to bedside?
yes.
All right. Describe what's going on at that, what time it happened, why he's called, etc.
So I believe it was somewhere in the 10 o'clock hour.
So this is about 3 hours into your shift.
Yeah, that it was just, didn't seem like the pain medicine was kind of helping her. She was a lot more like rigid, tense, more labored breathing, grimacing. She had a tear running down her face. And after like talking with the son and the granddaughter, who also agreed that they thought that she was in more pain and wanted more pain medicine, I called Dr. Husel.
All right, so the 10 milligrams, based on your observations and the discussions with the family, because they know her best,
Correct.
we need to get something else or something more.
Correct.
You call Dr. Husel, what happens next?
Dr. Husel comes to the bedside, kind of assesses the patient, talks to the family about giving her more medication if they want it, and they agreed.
Okay. So what happens next?
So then Dr. Husel, we step out. He verbally told me the order of the 1,000 micrograms of fentanyl and the 10 of Versed.
Okay, I'm going to stop you there. He verbally orders it. What's the other way he could have done this, to your knowledge and your understanding at that time?
I mean, put it in himself.
And, okay, put it in himself, meaning it would go to pharmacy and then you could go get it after that.
At least that the order would have been put in.
All right, so you're given a verbal order. Is this inside the room or outside the room?
Outside.
And you said this was for how much?
1,000 micrograms of fentanyl and 10 of Versed.
Okay, and she had previously, for 3 hours, and then the hours before, been given every 15 minutes 10 milligrams of morphine.
Correct.
Are you familiar, did they teach at Johns Hopkins the concept of titration?
We would like titrate like drips, so it was taught.
It was taught. So
Some
could you tell ladies and
titration.
gentlemen of the jury what titration means, under your understanding?
Just starting with lower dose, and then if it isn't working, like going up in increments.
Are these big increments or small increments, based on your understanding of how this should be done?
I guess it would depend on the medication. I don't know the specific increments.
But small and then go to bigger. Is that right?
Correct.
All right. So, I'm sorry, you okay? All right, so were you familiar at the time with the equa-analgesic equivalency of morphine to fentanyl?
No.
Are you aware of that now?
Yes.
All right. So she's going from 10 milligrams of morphine to 1,000 micrograms of fentanyl. Do you recall her? I'm transitioning here, Judge.
Let's re-ask.
She was on how much morphine?
10 milligrams,
And then Dr. Husel orders how much fentanyl?
1,000 micrograms.
Do you recall the amount of midazolam, or if she was on any type of benzodiazepine as part of that 10 milligrams of morphine?
I know she had gotten it in the past, but I didn't give her any prior to that.
So she's not even on a benzo, to your recollection?
To my recollection, I don't remember.
And how much midazolam did he order?
10.
And this is outside this is outside the room, outside where the family is?
Correct.
Okay. How did you take it you were supposed to withdraw that medication from Texas?
To grab it now.
Okay. And to grab it now, how do you have to do it?
Override.
All right. What happens next? Are there any other nurses or other personnel around you as you receive this order?
Yes. Tyler Rudman, who was a nurse on our floor and also a nurse practitioner student, was around, and I had asked him just if this was like a normal palliative dose, because this was my first palliative patient. So.
Tyler Rudman?
Correct.
When you say there was Tyler Rudman was around, also a nurse practitioner student, are you talking about the same person, or is there another person there who was a nurse practitioner student?
The same person.
Okay. So at the time,
You want a sidebar?
No, the council is inserting facts in its questioning.
Okay,
Tyler
wow.
Rudman was not a student.
Okay. Overruled. Do you understand the question?
Yes.
Okay. Can you answer it?
I mean,
Would you like him to ask you again?
yeah. Yes.
Tyler Rudman, at the time, what was his role in the ICU, if you know?
So he was a staff nurse in the ICU, but he was going to school to be a nurse practitioner.
Okay, so for those that may not know, is nurse practitioner as far as education, experience, ability, whatever, above being a nurse? Is it like the next step?
Yes, correct.
So he's a nurse, but he's studying to be a nurse practitioner.
Correct.
Okay. The fact that he is a nurse, do you have more experience than you?
Yes.
Did that help you when you asked him this question, have confidence in his answer?
Yes.
The fact that he is a nurse studying to be a nurse practitioner.
Leading.
You are. Sustained. Rephrase.
Referring to his studying of becoming a nurse practitioner, did that also help you in the confidence in his answer to your inquiry about whether 1,000 was okay?
I don't know if knowing that, but that he was a nurse that had been on the floor, had more experience.
So tell me about your understanding of how nurse Tyler Rudman, right?
Correct.
Who, if anyone, is training him at this time to be a nurse practitioner?
Objection. Leading and calls for speculation.
Who, if
Okay.
anyone, is training him? How is that leading?
Okay, let's do a sidebar. Ladies and gentlemen,
Judge, I withdraw the question. I withdraw.
no, we're going to do a sidebar. These guys don't have any time with each other, so. Ma'am, you okay?
Yeah.
Take a deep breath, relax, okay? Mr. Zion, question, please.
All right, so we're all clear. You're talking about Tyler Rudman, right?
Correct.
Is there another guy that worked there named Troy Rudman?
Correct.
Were they related?
I believe brothers.
Okay, so we got Troy Rudman, Tyler. Just to add to this, was there a guy named Tyler Springer there?
Yes.
All right. This is someone different than Tyler Rudman, right?
Correct.
All right. We're talking about Tyler Rudman on this night. He's a nurse. We've gotten there, right?
Yes.
And what else, if you know, was he training to be?
He was in school to be a nurse practitioner.
And who, if you know, was training him to become a nurse practitioner?
Objection.
Yes, she knows.
Well, I mean, you're trained in school, I feel like, is your biggest trainer, but then you have, you work with different, you go on like the floor and do clinicals. So my understanding was he was doing like a clinical training with Dr. Husel.
So where is this conversation with Tyler Rudman happening in relation to the patient's room? Just looking back in your mind.
It was like outside the room somewhere in the ICU.
Is Dr. Husel still there when you're talking to Tyler?
No.
What did you ask Tyler?
Just if this was a normal like palliative dose of pain medication.
And were you assured, what if anything, did Tyler say for purposes of what you did next?
That it was a normal, like a normal palliative dose.
All right. What happened next? How far away are you from the Pyxis machine, for instance?
In the ICU, I feel like you weren't far from the Pyxis machine, and because they were close, there was multiple, so I wasn't too far. There was another nurse, Earl Huron, that also was hanging out and offered to kind of help me grab the medication and draw it up. So I also asked him, like, have you ever given this dose? Is this a normal dose of medication? And he said yes, that they had just given one of his patients the same kind of similar doses last week.
Okay. And what was your knowledge, what was your understanding of Earl Huron's experience at this point? How many shifts did you, your sixth shift, you think?
Yes.
And
On my own.
what about Earl Huron? How long had he been there, do you know?
He hadn't been there for too long, but he had PACU experience before coming
What's PACU?
post-anesthesia care unit.
Okay. And he said he offers to help you draw this up.
Correct.
What's involved physically with the act of drawing this up?
So getting the medication and in a syringe and drawing the medication from the vial into a syringe.
Okay. Do you remember the size of the unit dose that fentanyl was dispensed in the Pyxis machine back in 2018?
100 micrograms.
And so to get to 1,000, how many unit doses of fentanyl do you need to get?
10.
All right. Showing you what I previously marked for identification purposes. That's State's Exhibit.
It means that it's spinning back there and trying to fix it.
Judge, I think we're looking more at this issue.
Okay, let's stop. Do we need to discuss it again?
No, it's up to you.
I don't know what he's exactly doing yet.
He's going to do the little thing with the vials again.
Okay, you're assuming. We will see. He was quasi-objecting, anticipating what you were going to do.
Yeah, well, this is what I'm going to do. I'm going to show her this, Judge, if I can.
Yeah, that's fine.
All right. State's
Properly
Exhibit
mark it.
28B, previously marked and identified, has a unit dose of fentanyl, 100 micrograms. Does that look like what you pulled out of there?
Yeah. Yes.
And And so when Earl Huron offers to help you prepare this, why do you need help?
There were several vials. He also just kind of offered, and this, like I said, was my first palliative patient, so I felt comfortable having like another nurse with me.
All right. Several vials, 10 of these, right?
Correct.
So do you have like a little tub you put them in? How do you get these all at once? You put them in your pocket? What do you do?
I don't remember. I don't remember getting a tub or anything, just carrying them. So I don't remember if I put them in my pocket. I know Earl helped bring them.
Well, because you also got to get midazolam out, right?
Correct.
10 milligrams of that.
Correct.
Do you recall the unit dose that was dispensed in the fentanyl machine for midazolam?
I don't.
Was it 10 milligrams?
You're talking about the Pyxis machine?
What did I say?
Fentanyl machine?
Oh, the Pyxis machine. Sorry, Judge. Yes. Do you recall the unit dose for midazolam in the Pyxis machine?
I do not.
All right. Did Earl help you to prepare that dose as well?
Yes.
All right. So they're in these little, what is that, vial? We call that vial or ampules? Is ampule the word or vial?
Vial.
Vial. They're in these little vials. You got 10 of those, and you don't recall how many midazolams you needed?
I don't recall.
All right. So how do you prepare this to give to the patient?
You draw it up into a syringe.
Do you recall the size of syringe you would have needed for 10 unit doses or 1,000 micrograms of fentanyl?
I don't recall exactly which size that I used.
All right. Do you recall the size of syringe you would have had to use for 10 milligrams of midazolam?
I don't.
Okay. Where are you doing this?
In like another room.
Why are you doing it in another room?
When I got the order, Dr. Husel told me to draw it up in a different room.
Do you know why Dr. Husel told you to draw it up in a different room?
Just for like comfort of the family.
Can you explain that, please?
Just
Objection, calls for speculation.
Agreed, sustained.
What was your understanding of why he told you to draw it up in another room for the comfort of the family?
Objection.
I'll permit it. Do you have an understanding?
I mean, just to... There was multiple vials, so...
You were what?
There were multiple vials, so just for comfort of the family.
Your understanding, why would that make a family uncomfortable with multiple vials?
Objection, calls for speculation.
I asked for her understanding.
Overruled. I'll permit the question.
I don't know.
Okay. Next answer. Next question, I mean. That's my one faux pas of the day.
We all get one, Judge. Was Earl with you when you're in the other room prepping these vials and putting them in syringes?
Yes.
What happens next?
He drew up one of the medications, I don't remember which, and I drew up the other, and then I took them into the patient's room.
What happened next?
I scanned the medication and gave it to the patient.
In what manner did you give it to the patient?
We're
I don't-
lawyers and lay people. But he just wants to know, what did you use to do this?
So the patient's peripheral IV.
All right.
Say that again.
The patient's peripheral IV, like an IV
Okay.
in the arm or wherever it was.
Sherry had a needle in one of her peripheral veins, and you put it into that tube?
Correct.
All right. And did you do it, and what was Dr. Husel's orders regarding the rate at which it should be given? Was this a continuous infusion, for instance, or was it something else?
IV push,
And so what does that mean based on your training and experience?
like having it in that syringe and pushing it through the IV.
All at once?
Yes.
What happens next?
So after I gave the medication and signed it off, I was in the room for a few minutes with the family. The patient did look more comfortable, like her breathing like slowed because she was labor breathing. She looked a little more like relaxed. And then I went out into the nurse's station to chart.
What did you chart? Are you charting about Sandra or just catching up? What are you doing there?
But like catching up on some of my charting.
Okay. We've heard about this back charting. Can you explain what that is?
Like charting, so say you did something and you didn't get it charted at that point, charting it whenever you get a chance to sit on the computer.
And is that a regular practice of nurses and doctors, et cetera?
Yes.
All right. So when you're putting in times for these back charts, are those precise or are those estimates when things occur?
Both.
Okay, fair enough. So what's the next thing you're ever happen? You're back, you're catching up on charting at the nurse's station. How far away are you from Miss Castle's room and where the family is?
Not very far.
Is there a monitor that she's hooked up to that you can observe while you're doing your charting?
Yes, she was still hooked up to the monitor. It was just turned off in the patient's room, but we could see it out in the nurse's station.
What's the next thing you remember?
Are you guys hearing her okay? A little volume?
I'm going to step back and be abnormally loud again.
I don't recall what I noticed on the monitor, but I noticed that she may have passed, so I went into the room to look at the patient and called Dr. Husel to come to the bedside.
What happened next?
Dr. Husel came to the bedside, assessed the patient, and pronounced her dead.
What happened next?
I don't recall everything that happened next, but there were you do post-mortem care and cleaning up the patient and taking out IVs and then
Usual things happen.
yes, and then sending the patient
And that's
to the morgue. Then bringing the patient to the morgue.
all right.
Did you get all that? Okay.
All right. And that concludes your care that night on Sandra Castle.
Correct.
Let's talk about the charting that you were talking about, you're catching up on, but did you do any charting with Miss Castle?
I don't recall who all I charted for on that.
Do you recall seeing
In that
portions of her?
I coughed. It's okay.
Okay. Do you recall seeing portions of her medical records previous to your testimony today?
Portions, yes.
All right. Do you recall, did that have your name on them?
Yes.
Did those records appear to be fair and accurate?
Yes. I mean, so since it was my first palliative patient, I was trying to figure out what I needed to chart and where I needed to chart things, because I was never taught what I needed to chart in this kind of situation.
And I appreciate the precision of your answer, meaning you might not have put everything in there accurately when you reviewed it.
Objection, Judge.
I agree. Sustained.
Did these appear to be the medical records of Sandra Castle?
Yes.
All right. When you shook your head and said, yes, but, what did you mean?
I don't know.
Well, that's the answer we've got on record.
All right, we'll go over. I'm going to show you 12C. For the record, it's a client clip package prescription papers. Do you recognize those papers?
Yes,
Do you see your name indicated on those papers?
yes,
And do they appear to be on the medical records of Sandra Cassidy?
yes.
First of all, how old do you remember Ms. Cassidy? If I could have those back, please.
I believe she was about 80 or in her 80s.
Do you know when she came into the hospital?
I don't remember.
Did you do any prior care with Ms. Castle prior to the evening of November 13, 2018?
No.
All right. Showing you the first page of 12C, if I may publish, Your Honor.
Okay.
Here we see your name down here. That's you, right? LeChard RN Stephanie?
Correct.
On 11/13/2018?
Correct.
And 20-08, that'd be about 8:08 p.m.?
Yes.
So this is the evening of we just talked about what happened that evening, right?
Yes.
Okay, what does this action up here say you did on this?
This is just like reviewing orders that were put in by various people. If like previous nurses didn't review orders, there would be a whole list of orders to review.
Okay, so this indicates that you reviewed the previous nurse's orders?
Whoever put these orders in, yes.
Okay. Going to the second page of 12C, do we see your name here again?
Yes.
And up here we see order details. What is this talking about here?
That would have been when they were like extubating the patient. It was normal. It was like protocol to black out the monitors in the patient's room if the family members were present, just for their comfort, so it wasn't beeping, but it would still show up at the nurse's station on a computer.
All right. Going to the third page, do we see your name down here on 11/13 at 15:46?
Yes.
All right, but you weren't at work yet, right?
No, so that's just saying at the 2008 that I reviewed that order.
Okay, and what is that order that you specifically reviewed?
DNRCC.
So you knew that was her status as far as code?
Correct.
Going to the, where are you on this, Ms. LeChard? Just a moment, Your Honor, here, please. You described the discomfort that Ms. Castle was in. Did you talk about, you referred to the secretions in her throat?
She was gargling.
Is there medicine for that?
Yes, and we did give her that medication. It was glycopuricide.
Okay. Referring to next page in State's Exhibit 12C, do we see an order for that medication?
Yes.
And who was that order given by?
It was given by me.
Okay. Who was it ordered by? I'm sorry.
Oh, Dr. Husel.
And so you did give her that. That's you, meaning you gave it actually after Dr. Husel told you to, right?
Yes.
All right. And then looking at the next page on the 12C entitled Orders, Medication Orders. What is this? What are we looking at here on this page? And there's a laser pointer there if you need to use it to help your testimony.
The fentanyl order, and then the Versed order, the 1,000 of fentanyl, and the 10 of Versed, and that they were given by me.
So this indicates who was the doctor that ordered this?
Dr. Husel, yeah.
And at what time did he order this?
2257.
And what time did Dr. Husel order the midazolam/Versed?
The same time.
Okay. And does this indicate who entered and electronically signed this order?
Yes,
And who was that?
that was me.
All right. Can you tell the ladies and gentlemen of the jury what direct charting flow sheets are?
I'm not sure. But
Did you review any direct charting flow sheets in the medical records of Sandra Castle?
say that again?
Prior to your testimony today, did you review any medical documents entitled Direct Charting Flow Sheet for Sandra Castle?
I did see some, yes.
All right. But you just don't know exactly what they are?
Title, yeah.
Okay, very good. Referring to the direct charting flow sheet, halfway down entitled Pain Intensity Scale. Who does this appear to be for?
Sandra Castle.
And does this appear to be pain intensity scale as documented by various nurses?
Yes.
And what date does that appear to begin on?
This is like pain, I feel like reassessment? I don't know. But 11/10.
11/10?
Yes.
And is that consistent with the date she was admitted?
Yes.
All right. And do we see your name on this first page that ends on 11/11/2018? Down here?
In this section, no.
All right. Continuing on with the direct charting flow sheet pain intensity scale, do we see your name on this sheet anywhere?
Yes.
All right. And where do we see your name here?
At the bottom.
Okay.
I'm sorry. I didn't hear your answer.
At the bottom.
All right. And what date does that begin on?
The 13th.
All right. And at what time does that begin on?
7:18 at night.
All right. And is that consistent when you took over the care of Miss Castle?
Yes.
All right. And we don't have an answer to this. What's going on here? Why is there just a dash here?
I'd need to see like the top heading. I think that's just a pain
Is pain level acceptable?
that I just may not have charted that.
Okay. Do we see, continuing on with the direct chart flow sheeting, do we see your name here on the eye-opening response Glasgow? Do you know what that is?
Yes.
And what is that?
So that is like a kind of testing like neurological, how comatose the patient is, if they are.
And we see your name here at the last on 11/13 at 7:44.
Yes.
And what was her eye-opening response Glasgow?
No response.
Okay. What, if anything, based on your training and experience, does that indicate regarding your patient's Glasgow score?
The patient wasn't like specifically responding to pain by opening their eyes.
Okay. The next section is entitled motor response, correct?
Correct.
And is this part of the Glasgow scoring as well?
Yes.
And do we see your name on this page that we were just referring to anywhere?
No.
Moving on to the next page, do we see your name anywhere here?
Yes.
And where do we see your name?
At the bottom.
On 11/13 at 1944?
Correct.
And what was her response? What was her motor response on the Glasgow scale?
No response.
So, going on to her scoring, what score did you give her?
I think that a low score, so.
Is that your score?
Yes.
And what score did you give her for the record?
3.
And do you know how low the Glasgow score goes?
I believe 3.
Okay. Moving on in the direct flow charting, we have respiratory findings, correct?
Correct.
Are you familiar with this charting?
Yes.
All right. And going through this, do we see your name anywhere on this document?
Yes.
All right. And what do you note on 11/13/2013?
Labored breathing.
That she had labored breathing. Okay. Going on, are you familiar with level of consciousness, -CAM?
Yes.
Do you know what that is?
Just like, are they conscious? Are they responding to you? Are they...
Got to speak up. She can't hear.
Sorry. Are they conscious? Are they like responding?
Okay. And on 11/13, do we see your rating her level of consciousness?
Yes.
And what was her level of consciousness based on her CAM score?
Comatose.
All right. Going through the direct flow charting, is the next section orientation CAM?
Yes.
And are you familiar with what that is?
Yeah. Yes.
Moving on to the next page, do we see your name anywhere on this?
Yes.
And what did you, I'm sorry. This first part is orientation. Did you chart her orientation on the CAM score?
I don't see it unless it's at the bottom of this paper.
Oh, I'm
no.
sorry.
No, unless it's on the top of the other one. But
Well, moving on to the next page, we have the cognitive CAM. Is this a different charting?
I believe so.
What was her cognitive abilities on 11/13 at 1944?
Difficult to arouse.
The next section, behavior, mood, effect on the CAM score. Do we see your name on this page?
No.
What is her rating all the way down there, though?
Calm.
Moving on to the next page. What does her behavior, mood, effect continue to be?
Calm.
What did you rate her behavior, mood, and effect as?
Calm.
Moving on in the direct flow charting, the arm bilateral neuro exam. What is that about?
I don't remember exactly tests like what you do with this, but it was, I guess, just looking at are they moving their arms or having any movement.
Okay. And what did you rate Miss Castle's arm bilateral neuro exam at?
Flaccid.
And what does that indicate?
That she's not like moving her arms.
Is that consistent with being rigid?
No, but I mean, when I saw her, she was like very rigid, so.
Okay. So was this earlier than when you're talking about then?
The first, yes.
Okay. And moving on, that might actually just be a duplicate. I printed it out twice. This is the same page. That was her arm neuro exam. Did you do the same thing with her leg bilateral exam?
Yes.
And what did you rank her movement as?
The same, flaccid.
Flaccid. Respiratory activity. Direct flow charting. What did you rate her respiratory activity at?
I mean, she was just at rest because she was laying in bed.
Okay. What did you rate her sputum? I'm sorry, pronounce that word for me. Sputum?
Sputum?
Sputum, thank you. And what's sputum?
Like secretions, saliva.
That thing we're talking about,
Like
the stuff in your throat?
Yeah.
Okay. What did you rank her sputum at? Oh, I'm sorry, you're not even on there.
I did not, yeah.
Sputum consistency, I guess you did, down here at the bottom.
Loose.
Okay. also charting for support people. Do you guys chart how the family is dealing with everything in general?
I did, yes.
All right. And how is the family, according to your notes, dealing with everything at 1944?
Coping appropriately.
I'd like to talk about the medication administration record. What is that?
That's like where you find out if you have any medications due, what medications are ordered for a patient, whether they're as needed or scheduled.
Okay. Is that commonly abbreviated MAR or MAR?
Yes.
And does that indicate that the medications were actually given?
Now I'm used to it. We switched computer systems, but yeah, it would show if it was due or if it was given.
Okay. So referring to the MAR at 1903 on 11/13. This is for Sandra Castle. Referring to, this is the medication administration record.
Yes.
Is that right?
Yes, correct.
At 1903, so that's what time?
That was like 7:03 p.m.
Okay. That's right when you're getting on to work?
Correct.
All right. What was your patient, Sandra Castle, given by the nurse handing her off?
She gave her 10 milligrams IV push of morphine.
Okay. And for what would that have been for?
For pain.
Okay. Is there a corresponding note? Should be a corresponding. Okay. 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 And where is that in there? That's just in the Mars. You want me to go through the Mars, right? Okay. All right, is this the one next? No, this is not what I need right now. Sorry, Judge. This is it, right? Okay, thank you. And then at 1918, so that was 15 minutes before the day shift nurse gave her the morphine, right?
Correct.
And then what happens at 1918? So this would have been 15 minutes later?
Yes.
All right. And what happened? What was she given next?
So this looks like it's just like a pain reassessment.
Okay. Did you give her this morphine?
No, it's I believe that this was just a pain reassessment. It says pain relieved with medication. No.
Okay. So at 1933, what happens?
Then I gave another 10 milligrams of morphine.
All right. So this is from the day shift, the every 15 minutes, correct?
Correct.
And then at 1933, based on your assessment at 1918, she's given, per the order from the day shift, another 10 milligrams of morphine, correct?
Correct.
By IV push?
Correct.
And that's you, correct?
Correct.
And where is this? So this is So what are we looking at here in this form, pain assessment?
Identify for the record.
For the record, it's another page from State's Exhibit 12C, excuse me, titled Pain Assessment. For Sandra Castle.
These are pain responses.
Okay. And is this one at the bottom yours?
Yes.
All right. So you assessed her pain at 1918. At 1933, you gave her a shot of morphine. And at 1948, what did you note in the record?
That pain was relieved with medication.
Okay. With that 10 milligrams of morphine?
Correct.
All right. And other symptoms relieved with medication, what was your answer?
Yes.
And what is this, POSS?
That's how sedated the patient is.
All right. And what does this language over here mean?
So in this case, somnolent, she wasn't.
Okay, your voice is going
Sorry.
down. You should focus.
She
Raise it
wasn't
up.
responding to stimulation or
Okay.
verbal, physical stimulation, so not talking.
And this is after you had given her the 10 milligrams of morphine?
Correct.
All right. So at this point, the 10 milligrams is still working, correct? In your mind and based on your charting here?
Based on my charting, yes.
When was isn't this the one she just gave her? Okay. So we just left off there at 1948, right? Pain relieved with medication, yes. Correct? All of this stuff we just saw in your note?
Correct.
Somnolent? No response to verbal or physical stimulation, correct?
Correct.
All right. Is this stuff up here, what's this here at 2100?
That was a medication that they used to wash off a patient's mouth, clean it when they were intubated.
Okay, so that's nothing to do with pain medication, right?
Correct.
What's lorazepam?
It's Ativan. It's another benzo.
Yeah, speak up. It's another what?
Another benzodiazepine.
Stop for a second. It's human nature when you concentrate to lower your voice because you're concentrating. Okay, when you do that, we kind of lose you. Okay, so remember that. Talk out loud so we can hear what you're saying. I realize you're concentrating, but you got to help us.
Okay.
Okay? Because I was losing her. Were you guys losing her? See? And everybody does it. Don't worry, you're not anything special here. Okay?
You good, Judge?
Yeah, I was just going through the usual. When people focus on the screen, they tend to be quieter.
All right. Lorazepam, Ativan, I'll try to speak up. You said that was a what?
I believe another benzodiazepine.
What's the first benzodiazepine we talked about today?
Versed.
Versed? Okay. So she does get a benzodiazepine per this day shift order for pain and anxiety, correct?
Correct.
And how much did you give her at this time? 2141?
2 milligrams.
Okay. And did that have, and that was for?
Pain, discomfort.
Okay. And what's the next thing you give her? At 2221.
More morphine.
And how much did you give her?
10.
And this was by a push?
Correct.
And her pain score at that time was?
A 9.
Okay. So how long had it been between this morphine shot and the previous morphine shot?
If there was not any in between, I don't know if I had given any in between.
Showing you the first one, 1948. Was that the last shot before the second one here?
That's That's on the records that you're showing me, yes.
Okay, so between 1948 and 2221, that would be how long?
2.5 hours.
And these medications, are they on a schedule or are they PRN?
PRN,
And that means, again,
as needed.
all right. And then what's this last medication here for?
That's to manage like secretions.
Okay. All right. Referring to the next page in the medical administration records, what do you give her at 2236?
I believe that's another pain reassessment.
Okay. Pain relief with medication, what was the answer?
No,
All right. What is her sedation level?
still the same, the somnolent.
All right. And are you the one doing this pain reassessment?
Yes,
All right. And is that thereafter when she's given 1,000 micrograms of fentanyl?
correct.
Is that right? Do we have volume now? Okay. And not given Ativan, but midazolam.
Correct.
And how much?
10 milligrams.
Okay. So from those records, does it appear she was getting morphine every 15 minutes throughout your shift?
Not the records, yeah. Not based on those records that I just saw.
Okay. There were, how long of a gap between, I counted 3 times you had to give her morphine that shift?
2.5 hours.
What, if anything, happened regarding your employment and your licensure as a result of your treatment of Ms. Sandra Castle?
Objection.
I'll permit it.
So I did receive a notice from the nursing board that cited me. I had a hearing and I had a 6-month stayed suspension, which meant I could still work as a nurse, but I had to take some extra classes and have quarterly reporting from my employer.
All right. And was that as a result of the shot of it?
Objection.
Okay, speculation agreed, sustained.
What was that a result of?
Objection.
Sustained.
Why were you called to the nursing board?
For
You can object.
Let's go sidebar. It's been a while. Or better yet, we're coming up to a break. Should we take a break?
Judge, I think I'm almost done.
I got people wanting a break over here. Let's take 15 minutes.
All rise.
We'll see you guys in 15 minutes. Remember the admonition. I guess. The ones in back are 2 minutes behind this one out here, and I'm syncing off this one, okay, because it's the only one I can see. So whatever the time, just add 2 minutes to it, then you know your time. Fair enough? Mrs. Ion.
Thank you. What, if anything, did you hear from the nursing board after this?
That I was like,
Okay, let's rephrase, because you did this, and there's been a gap. So let's bring her back to where you were before.
Did you receive a notice of any kind from the nursing board after November of 2018?
yes, I received a notice of opportunity for hearing.
All right. Regarding your employment, was your employment with Mount Carmel affected in any way after November of 2018?
I was placed on administrative leave in December of 2018
How long did that administrative leave last?
until July of 2019.
What, if anything, happened after July of 2019?
I was brought back on staff.
All right. Did you go back to Mount Carmel West in the ICU?
No, I took a job at Mount Carmel St. Anne's.
In the ICU?
No,
Where do you work now?
I work in maternity.
Okay. And that's where you presently work still?
That's where I presently work.
All right. And looking back on the medical records, do you recall if Ms. Castle had just been extubated prior to your arriving to work at around 7 o'clock that night?
I believe she was extubated sometime in the 3 to 4 o'clock hour.
All right. Why is she still, if you know, why is she still in the ICU at 7 o'clock? What would normally happen to somebody extubated that's alive several hours later?
They would normally, I guess, be transferred to the palliative floor, but there were arrangements during the previous shift to keep the patient in the ICU because that patient had a lot of family, and just for the comfort of the family, was my understanding. They had decided to keep the patient on the floor.
So she's receiving palliative care in the ICU during her shift, basically.
Correct.
And was that your understanding of the normal course of things?
At that moment, I don't know that I knew the normal course of things.
And how many shifts had you worked prior to this on your own?
6.
Thank you. I have no further questions.
Mr. Myers?
Okay. This is just a duplicate. This is what I showed. It was the same thing. This is her deposition.
No. Where's the records?
Right here. And I just went through them so that like this. I just flipped them over. So it should be good if you start at the beginning. Back here, this should be the first page. Sorry, I didn't get back. All right.
Police report. Mr. Zion. Good afternoon, ladies and gentlemen. Good afternoon, Mrs. LeChard.
Good afternoon.
Okay, I'm going to ask you a few questions. I'm going to try and go chronologically, if that's okay.
Yes.
Okay. First off, you were asked about overrides, and then you compared it to, I guess your question about comparing it to your prior job at the Cleveland Clinic. Do you remember that question?
Yes.
You didn't work in the ICU at the Cleveland Clinic, though, right?
I did not.
So, fair to say in an ICU, things are happening a little more rapidly, correct?
Correct.
Okay. And patients are far more in critical condition than they were in, I think you worked in the transplant?
Correct.
So, very big difference in the number of emergency situations that would require an override, right?
Correct.
Okay. So I just wanted to clear that part up. Now let's talk about when you first got on staff, when you first came to work that day. Okay. Now, when you first got there, you said you got briefed from the prior nurse as to Miss Castle's condition, right?
Correct.
And you learned that she had been palliative, extubated, and her family wanted to withdraw care, correct?
Correct.
And that is because life support was going to be withdrawn, and basically she would have moments to minutes to hours left to live, correct?
Correct.
So the last, and you said there were a lot of family members there when you got there?
There was.
Okay. And this was basically the family's last opportunity to say goodbye to Miss Castle, correct?
My understanding when a lot of the family left is that they were saying goodbye for the last time.
Okay. And over the course, you said she was extubated around 3 or 4 p.m. that afternoon, right?
Correct.
And when you look at the MAR, I guess you were also briefed on what kind of medication she was on and so on, right?
I don't recall like specifics. I do just remember that she had mentioned the 10 milligrams of morphine.
Okay. So it was your understanding, too, that she had been given several pain meds beforehand, right?
Correct.
And none of it was working, right?
Correct.
Okay. So this family, this large group of family, was seeing Miss Castle going through some pain and suffering. Is that fair to say?
Yes.
And their last memories of Miss Castle would be those before they said goodbye.
Correct.
And when you gave the 10 milligrams of morphine, you gave it to her to alleviate her pain, right?
Correct.
And that was your intent and purpose?
Correct.
And when you first got there, I guess I'm going to show you Joint Exhibit 12, page 812 through 813. Do you see that there?
Yes.
Okay. Do you recall going over this with the prosecutor?
Yes.
Okay. And he asked you specifically about this entry here, where the pain on 1948, the pain was relieved by medication, and you wrote and you checked yes. Do you see that?
Yes.
Okay. He didn't show you the next page. Do you recall seeing the next page of this document?
No.
Okay. On the next page on this document, at 2236, it asked pain relieved with medication, and you indicated no. Do you see that?
Yes.
Okay. Now, I would like for you to take us to the ICU on that evening. You described under direct examination that Ms. Castle was gurgling. Do you recall that?
Yes.
Okay. And this is from fluid in the lungs, from what you recall?
Yes.
And you found it disturbing?
It was, I mean, you could hear it throughout, like, down the hall in the ICU. Other nurses had commented on it as well.
Okay. So at this point, you know you believe she's in pain, right?
Correct.
And you're hearing her gurgling to the point where you can hear it all the way in the other end of the ICU.
Tell her to be patient.
Correct.
And it's so bad that other nurses are telling you about it.
Correct.
And
Mr. Baez,
is still present.
sorry to interrupt you. We have a 3 o'clock Zoom scheduled. Are we going to hold them off?
Your Honor, I texted and emailed and told him that it would be closer to 4.
Okay.
If we could just...
I just have the media people saying, we got ready to put this up, but they can all see it 4.
Thank you.
Sorry to interrupt you there, but
It's okay, Judge, I understand.
scheduling is like herding cats.
Mr. LeChard, I want you to take us back to the ICU one night. Ms. Castle is gurgling loudly, right?
Correct.
And you could hear it throughout the ICU.
Correct.
And she's also moaning.
Correct.
And you had mentioned that you could see a tear dropping down the side of her face, correct?
Correct.
And you also testified under direct that when you observed her, she was also grimacing in pain.
Correct.
And that her family was there to share her last moments of life with her, correct?
Correct.
And at approximately $21.41. I'm sorry. I want to make sure I get the right time. I'm sorry. Approximately 22:26, and I'm showing you Joint Exhibit 896. I'm sorry, Joint Exhibit 12, page 896 to 900. At this point, Dr. Husel orders, can you pronounce that for us?
Glycopyrrolate.
Okay. And that is to potentially address the loud gurgling that she is going throughout where everyone can hear it throughout the ICU, right?
Correct.
So this is the first time that you reached out to Dr. Husel to get some type of medication, correct?
Correct.
And you properly advised him of what your patient was going through, right?
Correct. Yes.
At this time, Dr. Husel didn't come over and order any fentanyl, correct?
Correct.
That was not his first choice of medication. It was, in fact, this one, correct?
Correct.
And subsequent to this, ma'am, Miss Castle continued to suffer, did she not?
She still looked like she was in pain, yeah. Severe pain.
And while Miss Castle was going through this pain, you were approached by the family, were you not?
Correct, yeah.
Okay. You didn't testify about that during direct, did you? About the family coming to you to ask you for more pain meds?
I don't believe so.
Okay. And the family comes to you, and it is now, everyone had already said their goodbyes, correct?
Correct.
And before I go any further, there was one record that I don't think you reviewed under direct as well, and that is Joint Exhibit 12, page 486. And I want to reference the time. I want you to look at the time where your name is mentioned here. 7:44 is shortly when you got there, correct? After you had gotten there, about an hour? Does that sound right?
Yes.
Okay. And her pulse oximetry is at 90, is it not?
Yes.
Tell the ladies and gentlemen of the jury what pulse oximetry is.
It's a reading of like the oxygen in the blood.
Okay. And that's important to sustain life, right?
Correct.
Okay. And at this time, when you shortly arrived, she's at 90, and the range is 90 to 100, correct? That's the optimal range?
Correct.
Okay. And then right around the time where she is suffering and gurgling, have you heard the term death rattle before?
Yes.
Okay. Would that accurately describe what you heard?
Yes.
Okay. And does it sound like boiling water or something like that? Or like someone's drowning?
It sounds like a drowning.
It sounds like a person's drowning.
Yes.
And you could hear it throughout the ICU.
Yes.
And as you're hearing this, you see her, which is around 10 p.m., 2200, before that medication was ordered. Again, I apologize for not being able to pronounce it right. That was ordered 26 minutes later, right?
Correct.
Okay. But at this time, her pulse oximetry is at 66. Do you see that?
Yes.
That's dangerously low, is it not, based on your training and experience?
Yes.
So she's actively dying at this point.
Her pulse ox is dropping, yes.
Her pulse is dropping.
Yes. The oxygen level?
And yes. And then the family approaches you and asks you for more pain meds because they don't want to see her suffering anymore.
Yes, so like I was in the room when we were talking and they thought she looked more uncomfortable and wanted more pain medicine.
And it's at this time that you went out and got Dr. Husel to come to the bedside.
Correct.
And when Dr. Husel came, he spoke with the family.
Yes.
And he assessed the patient.
Yes.
And after speaking to the family and assessing the patient, he then informed the family.
Objection, Your Honor.
Sustained.
There was a time, there was a decision that needed to be made by the family, correct? To get these pain meds?
Correct.
And tell the ladies and gentlemen of the jury how that decision went about. How did the family go about making that decision?
Objection as to hearsay, Your Honor.
Sustained.
Ms. LeChard, in order for, well, let me pose it this way so I can best pose it this way. There was a decision that the family had to make, correct?
Correct.
Okay. And as part of the decision, this was Dr. Husel had to give the family all of the facts.
Correct.
Okay. And that included the information of potential side effects of the medication, correct?
Sustained.
Did the family become aware through this transaction, through this negotiation, or through this discussion, that there were potential side effects to the medication?
Sustained.
in your training and experience, based on your training and experience, did the family receive all of the information that they needed to make an informed decision?
In that moment, yes.
Okay. And would that have included the potential side effects of the medication?
Sustained.
Can you describe Dr. Husel's demeanor when speaking to the family at this time?
He was kind, patient, caring when talking to the family.
Okay. And was he informative?
Yes.
Was he detailed?
Yes.
Did he leave the decision up to the family, or did he tell them what he was going to do?
He left the decision up to the family if they wanted the patient to get more pain medicine.
And when describing the medication,
Objection, Your Honor.
Sustained.
can I have just a moment, Judge?
Yeah.
Now, after making what you believe was an informed decision, that is when Dr. Husel asked you to, he gave you the order of the 1,000 fentanyl and the anti-anxiety medication, correct?
Correct.
And
Just let you know.
before I ask you about these vials, did you think that he would, during the discussion with Dr. Husel and the family, did you, well, let me put it this way. If Dr. Husel had hidden important information about the side effects of the medicine, would you have spoken up and informed the family and given them more information?
Yes.
Okay. And did you have to do that?
No.
Now, in your entire time as a nurse practitioner, I'm sorry, as a nurse, both at the Cleveland Clinic and at Mount Carmel, has a doctor ever told you when ordering medication, get me 1, 2, 3 vials, give the patient 3 vials of medication?
No.
So it's never done by vials, right? It's done by either milligrams or micrograms or whatever measuring system they're using.
Correct.
So after the family made this decision, Dr. Husel then asked you to do the syringe in another patient's room, correct?
In an empty room.
In an
Correct.
empty room. I didn't in front of another patient. And you understood that to be for the comfort of the family, right?
Correct.
Because I presume they were going through enough at this time. Fair to say? say?
Fair to say.
Needles, in your experience and training, needles can be quite frightening to people, wouldn't you say?
Yes.
Now, ma'am, after giving the medication, did Ms. Castle continue to suffer?
She looked more comfortable. She didn't look like she was in pain like she had.
You didn't see her you didn't see her displaying any more of the symptoms that she was previously?
Correct.
She started breathing a little normally and not agony,
Correct.
and she wasn't doing the death rattle anymore?
Correct, or at least not as bad.
And you didn't see any more tears fall down the side of her face?
Correct.
And did you feel, was it your decision that at that time you could leave the family alone with her at bedside to spend their last moments?
Correct.
And that was her only son?
I don't know. I think she had more kids because there was a lot of family in the beginning.
So, but that was with her son, and her granddaughter got to be with her in, would you describe it, a peaceful state?
Yes.
And that's when you went over to the monitoring station and you were able to observe her vital signs on the nurse's monitors, correct?
Correct.
And that's attached to a computer, and all of that is working at the same time that the family is spending their last moments with Ms. Castle.
Correct.
And then after that, when you recognized that perhaps Ms. Castle had passed away, you went and got Dr. Husel?
Correct.
And when Dr. Husel came in the room, tell the ladies and gentlemen of the jury what his demeanor was like when he came back in the room to declare her dead.
The same, like calm, kind, caring.
And those are the words that you would use to describe Dr. Husel during Ms. Castle's care and his interactions with the family. Kind, caring, compassionate?
Yes.
I have a couple of post questions to ask you. And the first one was, when the police had come to speak with you, did you have a lawyer?
No.
Did you think there were lawyers about? Is that correct?
There was a lawyer that had read me my rights like right before.
Did you think that he was your lawyer?
No.
Did he sit in the interview when you spoke with the detectives?
No.
Did you think that the detectives, did you get the impression that the detectives knew what kind of questions to even ask you?
No. Not.
In fact, you believe that they were kind of learning as they were going along. Is that a fair statement?
That's fair.
And you didn't even know that the police were going to come and question you on that day, correct?
Correct.
They kind of surprised you with this?
Yes.
Did you have an opportunity to make a phone call, to talk to someone or call your husband? Or
Hold on.
Need a lawyer?
Time out. Stop. Sidebar.
I'll withdraw the question, Judge.
Okay. You're to disregard the question, ladies and gentlemen.
that she was having, correct?
Correct.
You didn't have any ill intent to harm her in any way, shape, or form.
No.
And you also understood that the intent was not to hasten her death, but to treat the symptoms and make her comfortable.
Correct. Correct.
Can I have just a moment, Judge?
Yes.
I have no further questions. Thank you, Mr. Chairman.
Mr. Zion?
Actually, I just have one question. Sorry.
Counselor, you sat down.
Sorry, Judge. I
Make
know.
one, because every time you say one question, it's 5.
Sure. All of the things that you told us about her death rattle, her suffering, her what she was going through that evening in the ICU, all the records in the world would never fully describe it, correct?
Correct.
I lied. I literally just have to repeat more.
Make it quick. We've got time considerations here.
I asked all of these, and you weren't even trained on how to chart in the ICU during a palliative extubation, were you?
No.
You sure?
Yes, sir.
I'm waiting for you to sit down before I bring Mr. Zion up. Mr. Zion, any redirect?
Yes, John. Remember, defense counsel asking you, a decision had to be made by the family. Remember that question?
Yes.
When was she palliatively extubated?
Before my shift, so 3, 4 o'clock in the afternoon.
And is that when she would have been changed to do not resuscitate comfort care?
Yes.
And so at that point, before your shift, the decision had been made to just keep her comfortable throughout the dying process?
Correct.
So that decision had been made hours before.
Objection, Judge.
You just asked to sustain. You just asked her when it occurred. Are you transitioning?
Yes. That decision had been made hours before, right?
Correct.
What decision are you referring to now that needs to be made?
Just if they thought she was looking more uncomfortable and needed more pain medicine.
That's the big decision you're talking about?
Yes.
As part of your training and experience, you are aware, or are you aware, that you cannot...
Objection, leading.
I haven't heard the whole question. Go ahead.
Are you aware that as part of your duties as a nurse, you cannot cause someone's death with excessive pain medication?
Objection.
Overruled.
Correct.
Right. So what's the big decision the family needs to make here?
Objection. Counsel's characterization.
Overruled.
The issue is to receive more pain meds, that was what it was.
Okay, you made your point. Overruled.
State it again.
What's the big decision that needs to be made at 10 o'clock at night now?
Objection, Judge.
I've already ruled.
A big decision. This is strictly argument and not a...
I've ruled, counsel.
Just that if she needed more medication than what she was receiving, more pain medication.
And how much pain medication was she on up to this point?
10 milligrams of morphine.
And how much pain medication did Dr. Husel order?
1,000 micrograms of fentanyl.
Mr. Defense Counsel asked you, Based on your training and experience, did the family have all the information in the decision up to that point? Remember that line?
Yes.
Your training and experience, how many shifts had you worked at this point?
6.
So the context of that question is in the 6 prior times you had worked in the ICU.
Objection, Judge.
I'll permit it.
Correct in my training and orientation.
But you had no training in palliative care at that point, correct?
Correct.
And this isn't palliative extubation, this is actual palliative care, right?
Yes.
Because she should have been transferred to the palliative floor, right?
Correct.
Objection, Judge. Calls for speculation.
Sustained.
I move to strike.
What was the standard?
Ladies and gentlemen, disregard the question.
You said earlier that she was not transferred to the palliative floor.
Correct.
Is that different than how it should have normally been done?
Objection, Judge. Calls for speculation.
No, I'll let her.
From what was told to me at report, she would have been
Objection.
transferred out.
Speculation.
Okay, so you don't know for yourself?
No, because I was never trained on.
Did you review the note in the medical records that talked about that as part of your preparation today?
Objection. He's asking her at that time, and now he's asking her.
No, he's moved on, but that's okay. Did you review the notes?
There was an order to transfer her out.
After
That
how
was
many
reviewed.
hours?
After 4 hours.
And why wasn't that done?
Because a decision was made prior to my shift for the comfort of the family to keep them in the ICU.
So you've got this extubated patient still in the ICU, and she's being really loud?
Yes.
You can hear it down the hallway?
Yes.
It's disturbing?
I mean, it's hard to hear.
Yeah. And she's not even really an ICU patient, is she?
Objection.
Sustained, asked and answered.
Is she on a ventilator at this point?
No.
Is she being treated with intensive care at this point?
No.
Is she given palliative comfort care at this point?
Yes.
Is she still on the ICU floor at this point?
Yes.
And is she being very loud, and are the noises she's making hard to hear?
Yes.
And a decision had to be made by the family, right?
Correct.
That, you recall, the defense counsel characterizing that, that's the conversation Dr. Husel had. A decision had to be made by the family.
Objection, Judge.
Can you answer that?
Correct.
Okay. You testified earlier, Mr. Baez said that all the pain medication earlier had not alleviated her pain. Do you remember that?
I remember talking about those records, yes.
He said none of it was working. Remember that?
Yes.
As part of the medical records on this and part of your handoff care that night, do you recall seeing the pain assessment form from earlier in the shift?
Objection.
I think we're outside the cross, aren't we?
This was the question. He said none of the previous pain medication doses had worked. And she answered yes. And that was her knowledge that none of it had worked.
Go ahead.
Do you remember reviewing?
Objection, Judge. These are not her records, and she testified she did not review those records.
Noted, overruled.
Do you remember reviewing the earlier pain assessments or during the handoff, talking to the person that had cared for her earlier in the day?
I don't know if we talked about the pain, like assessing her pain.
this is you right here on 11/13 at 23:57, correct?
Correct.
And this is the previous nurse that was taking care of them, correct?
No,
What about up here?
not the nurse prior to my.
Okay, the two previous pain response form notes, though, by the nurses, those are those two previous notes there, right?
Yes.
Oh, okay, I'm sorry. It's this one here, on 11/13 at 3:44.
Okay, hold on. You got an objection?
Yes. Those entries were before the extubation, Judge.
Okay, that's a matter of fact.
Did you talk to the nurse that handed her off to you?
Yes.
Do you remember him talking about 10 milligrams of morphine?
Her, yes.
For purposes of what happened during your course of treatment, did he tell you whether that was a high dose or not?
She had mentioned that
What
it
did
was
she
a high
say in
dose.
regards to that for purposes of your treatment of this patient?
Repeat it again.
Objection.
Sustained as to the format of the question, rephrase.
For purposes of your treatment of Miss Castle, for purposes of the medical treatment of Miss Castle, what, if anything, did you learn about the 10 milligram dose of morphine that she had been receiving as needed after extubation?
That it was like a higher dose and that she had given her some.
Okay. The defense counsel said you didn't testify on direct about the family coming to you on bedside. Do you recall testifying on direct about talking to the family about her level of discomfort?
Yeah, I don't remember all the
Did you talk to the
questions.
family about her level of discomfort?
Yes.
Right. And
Yes.
did you listen to what they had to say because they know her best?
Yes.
Okay. And Mr. Bias said or asked you, they didn't want her to suffer anymore. Do you remember that question from the defense counsel?
Yes.
And so a decision needed to be made. Remember that question?
Okay. Slow down. Rephrase.
Do you remember Mr. Baez asking you, in regards to your conversations with the family, they didn't want her to suffer anymore?
Objection, Judge. That wasn't my question.
Okay. Do you understand the question? Do you remember Mr. Bias talking about that issue?
Yes.
All right. And then asking you about a decision needed to be made.
Objection, Judge.
Do you remember him asking you that?
Yes.
Have you ever had Mr. Baez ask you about the vials? Remember the 3 vials? You put them up here. Remember that?
Yes.
You ever have a doctor ask you to give that much fentanyl to anybody besides Dr. Husel?
Objection.
Okay, sustained.
You said the decision that had to be made.
Objection, Judge. Again, this mischaracterization of my questions.
Okay. He hasn't got the question out yet. I don't know.
the decision that had to be made was to whether or not give her more pain medication?
Correct.
Asked and answered.
Okay.
And,
He's going with this somewhere. I'm waiting for him to get there.
thank you, Judge. And she had received 10 milligrams of morphine previous?
Okay, that's been asked and answered.
May I?
Well, I'm waiting for you to get to something that's appropriate.
And how much did he increase that pain medication to? And after that decision had to be made with the family?
Objection.
Sustained.
How much did he increase that medication to?
Objection.
Sustained.
And nothing further.
Anything on the pre-procedure pain scores?
Yes, Judge.
Is it your usual one question?
2 or 3?
Sorry, punching late in the day.
Ms. LeChard, I want to ask you about a document that counsel had just shown you about the pre-medications. This is you at 7:18 p.m. on the 13th, correct?
Correct.
And then you were asked about 0344 on the 13th, correct?
Correct.
And that was earlier the day before? I'm sorry, the same date, but 3 in the morning, correct?
Correct.
And then the other time you were asked was 3 days earlier at 01 in the morning, almost 2 in the morning, correct?
Correct.
And the characterization of having 10 milligrams of morphine, that was...
No. Outside of your permission.
Okay. Were you aware of the prior medications that she received for pain, that she had received 6,000 micrograms of fentanyl in the 3 days that she was
Sustained,
a patient?
outside the scope.
I have no further questions.
Ladies and gentlemen, disregard the last question. Okay, ma'am, you may step down. Just hang tight for a second. I'm going to send them out for 10 minutes while we put up the screen and get everything situated. Okay? Figured you guys could use a leg stretch. I could. Okay? Remember the admonition? 10 minutes for us to get things set up. Just relax. You stand up while they go out.
Okay.
I'm the one who gets to sit. And I probably shouldn't, but I do. They know I'm respectful of them. I heard you guys got cheesecake today. Oy vey. Okay. Ma'am, you're excused. We just let them get out of here first. Let's get it set up. We'll get Paul over here.
She can leave, right?
Yeah, she can leave. I told her she's excused.
You're good, Ms. LeChard.
Anything for the record before we start the process? Anything for the record, Mr. Baez?
No, Judge.
Okay.
So whatever you think of that.
gentlemen, thank you for your patience. Ms. Grubb, call your next witness.
Thank you, Your Honor. This time we call Dr. Charles May, who is appearing on Zoom.
Dr. May, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay? I need you to state your name for the record and spell it for my court reporter.
Okay. First name is Charles, middle name Barry, B-A-R-R-Y, last name May, M-A-Y.
Thank
You may
you.
proceed.
And Dr. May, are you a medical doctor?
I'm a doctor of osteopathic medicine.
Thank you. And when and where did you receive your training?
You talk about the medical school?
Yes, sir.
Okay. When I attended medical school, it was called the Kansas City College of Osteopathic Medicine. I believe now it's called Kansas City University of Medicine. I graduated in 1976.
Okay. And when did you become licensed to practice medicine in the state of Ohio?
1977.
Okay. And during these years, since then, have you been practicing medicine in Central Ohio?
I have. Since the onset of the pandemic, I have just been doing telemedicine visits occasionally.
Okay, thank you, sir. Sir, did you receive an email from me yesterday which included some medical records and a death certificate?
Yes, I did.
And is that death certificate bearing a registrar's number of 20180000694?
Well, if you give me a second, okay.
Sorry.
I didn't know where it was. Okay. Yes, I see it.
Okay, and is this a death certificate for Frances Marlene Burke?
That is correct.
And was Frances Burke a patient in your private practice of medicine?
She was, yes.
Okay. Do you remember this lady?
I do very, very vividly, yes.
Okay, thank you. What did you list as her cause of death?
The immediate cause of death was an acute intracranial bleed. In other words, she had bleeding into the brain.
Okay, thank you. And
Okay.
what is the date of her death?
Okay, let me look again here. It looks like January 14th, 2018.
Thank you, sir. And what date did you sign this death certificate?
January 16th, 2018.
Okay, thank you. And did you attend her at her death or demise?
No, I did not.
Okay. Why do you feel that this death certificate was incumbent upon you to execute it?
Well, that's a good question. In my experience, if the emergency room doctor doesn't sign the death certificate, or the attending doctor in the hospital doesn't sign the death certificate, they usually go to the primary care physician to see if there is any if that physician would know any medical reason why this patient might have passed away.
Okay.
If not, I believe it has to go to the coroner.
Okay. Have you reviewed the medical records relating to her last illness and death prior to yesterday?
I did when I signed the death certificate, yes.
Okay. All right. Thank you, sir. Nothing else.
Ross?
Your Honor, a brief moment to set up technologically.
We're going to take our chances with it when we've been using the overhead?
Wait,
Okay.
Can I use the overhead to share things with him?
Use the overhead. It's been working. I just don't know if it's going to work on the screen where you can see.
That's what we need.
Well, I understand that. Let's try it. Should put a document up there, and I'll ask him if he can see it.
Let me see if I could expedite things, Your Honor. Dr. May, good afternoon. I know you have a doctor's appointment. I'm going to try and get you out of here as soon as possible, okay?
That would be fine.
Are you in Florida yet?
Excuse me?
Are you in Florida yet?
No, I'm home. The sun is out here, but I am in Columbus.
Doctor, do you have those medical records that the state emailed you yesterday that you indicated you reviewed prior to doing Ms. Burke's death certificate? Do you have them on hand?
I printed out the death certificate from the email. There was 198 pages of other records I did not print out.
Okay.
And I reviewed maybe the first 4 or 5 pages, and that was it.
Okay, doctor. We're gonna have to do that, unfortunately.
See if it works.
Did you want to try this first?
I guess this is the cord.
Oh.
No.
I don't think I have this.
Because mine's still spinning.
This disability.
Which cord do we have to plug in, Paul?
Yes, you want.
Oh. I don't have an issue cord.
We used your laptop the last time we did this.
Yeah, but we did it from here specifically.
Okay, so we're going to have to do it that way.
Okay. That's something happened here.
I guess this is the problem with Zoom witnesses.
Okay. Which one do you want me to pull up first?
Page 6.
You can assist. We're sending in the first 2. There it goes. It's start, but it's not up there yet.
Oh,
There we go.
All right. Doctor, can you see this medical record?
I can see part of it, yes.
Okay, and just to clarify, this is a medical record for Ms. Burke, correct?
Yes, that is correct.
And it's her discharge summary done by a doctor named Wagner, correct?
Yes.
Okay, now let's scroll down to, okay, right there. Do you see the primary care physician is listed as yourself there, correct?
Correct.
And the active and final diagnosis was compression of the brain, right?
Correct.
And for the hospital course, it says C-H&P, correct?
Correct.
Okay, now let's go to page 9, please. For the record, I'm referring to Joint Exhibit 6, pages 6 through 13. Page 9. Okay, perfect. Okay, doctor, do you see here the history and physical that was referenced in the discharge summary?
I see part of it, yes.
Okay. Do you see the portion that lists history of prison illness / brief note?
Yes.
And again, this was done by Dr. Wagner?
That's what it says.
Okay. So, just to clarify, Ms. Burke, per this document, arrived to the hospital with sudden onset right-sided weakness with an altered mental status which progressed to obstination. Is that accurate based off what Dr. Wagner put in his history and physical?
That's correct.
And she had previously been on Xarelto for pulmonary embolism, correct? Did you get that, Sam? No. Can you repeat your answer? I'm sorry.
That is correct.
Okay. And you know, as her primary care physician, that she had been taking Xarelto for a pulmonary embolism because you had seen her after she had seen you a couple months prior to this for throwing up blood, right?
For what type of blood did you say?
she was having issues where she was vomiting blood a couple months prior to January 14th of 2018, correct?
I don't remember that. We're talking 3 or 4 years ago, and I do not have her chart, but it certainly is possible.
Okay. I want to direct your attention to the sentence that starts with neurosurgery. Do you see that there?
Yes.
Okay. And it indicates here that based off her injury, that neurosurgery was notified, but that no interventions were necessary. That's accurate according to this document, correct?
Correct.
And that the family elected to withdraw care due to the severe findings and worsening neurological exam, correct?
That's correct.
Now, let's go to page 23 real quick. Okay. So, I just want to talk to you real quick about how she first appeared at the hospital. Scroll down to where it says Constitution, please. Right there. This is the emergency urgent care note from Ms. Burke when she arrived at the hospital, correct?
Yes.
And it indicates that she arrived at the hospital with agonal respirations and vomitus coming from the mouth. Is that accurate?
That is accurate.
So she arrived with a brain injury, struggling to breathe, and vomiting from the mouth. Correct?
Correct.
Okay. Let's go to page 10, please. You see here, doctor, this note by a doctor named Closer on January 13th of 2018?
Yes, Douglas Closser, I would say. Yeah, C-L-O-S-S-E-R. Correct.
Okay, doctor. And this is the day prior, or rather hours prior to her dying, correct?
I'm not sure the exact time of her death, but yes.
Okay. You see there the last two sentences of that paragraph where it states that the proposed shutoff and the patient began to decerebrate posturing. Do you see that?
Yeah, decerebrate posturing, correct.
And decerebrate posturing is when someone involuntarily has an abnormal body posture, correct?
Correct.
The arms and legs stick straight out involuntarily.
Correct.
The toes point downward.
Correct.
The head and neck are involuntarily but forcefully forced backwards. Correct?
Correct.
The muscles are tight and rigid when this is occurring.
Correct.
So just to bring this up to date, she arrives at the hospital struggling to breathe, vomiting, with a brain injury, and has involuntary posturing forcing her to be in an abnormal position, correct?
Correct.
Okay. None of that would be comfortable, right?
I do not know.
Sustained.
Fortunately, it's never happened to me, and most people...
Doc, stop. There was an objection. I sustained it. You don't have to answer the question.
Okay. Sorry. I did not hear that, sir.
Well, this is one of the problems with Zoom. Relax. You're good.
Okay.
Scroll down to the bottom for impression and plan. Okay, this is the next page.
You said 9.
11. All right. There. This is the next page of that same document, doctor, just to orient ourselves. Do you see where it says under impression and plan?
Yes, I do.
And it indicates that her brain injury is devastating, correct?
That's what it says, yes.
And it says that she has evidence that the pressure in her brain is increasing and herniating, right?
Correct.
Could you read the next sentence after that, please?
Sustained.
Does this next state, does it not state?
Again,
Sustained.
and we could just going to read the order.
You're asking, he doesn't have any independent knowledge. You're asking him basically to recite a report that's already into evidence.
Doctor, you were emailed these documents by the state last night, were you not?
Yes, I was.
To prepare for your testimony today, right, doctor?
I was not asked to read the entire package of papers, no.
But you were here to testify as to what you put down as her cause of death, right?
Right, but I did not have these records when I signed the death certificate.
Okay. So that when you signed this death certificate, you were unaware that other doctors had indicated that her brain injury would be fatal even with the most aggressive of care.
That's possible. I may have known that. I can't tell you that. Again, that was about 4 years ago.
Okay, doctor, based off what you did review in the medical records prior to signing your death certificate, you had no reason to believe that anything but this head injury that resulted in her struggling to breathe, having pressure growing in her brain, forcing herself into involuntary abnormal posturing in front of her family, you wouldn't have any reason to believe that anything else caused her death but that condition, correct?
You're asking for an opinion. You're giving hypothetical circumstances and you're as to another doctor's care. No.
I'm simply asking you.
No.
Did you have any reason to believe that this condition did not result in her death?
Same.
Sustained.
In your experience, with someone with this type of brain injury, with these types of symptoms, that would be fatal, correct?
Object.
Sustained.
Nothing further.
Redirect.
Nothing further, Your Honor.
Okay, doctor, thank you for your time. Good luck with your doctor's appointment. Be safe.
You're welcome. Thank you.
Take us down, Paul. Have a good day. Hang up. Hey, I'm getting used to it. Ms. Grubb, call your next witness.
Your Honor, we're out of witnesses for the day.
Do we sit and stare at each other for the next hour? No? You want to go home? We had a good day, so we got through a lot of stuff. So, ladies and gentlemen, we'll get started at 9 in the morning. It's my understanding we're bringing back Dr. Ely.
That's correct, Your Honor.
Okay, so the doctor's coming back in to finish up his testimony. If you remember, he had a family issue. So with that, have a great evening. Remember the admonitions. Be safe. David. I'll get him trained. He's only been with me 10-something years. Have a good evening, guys.
Thank you.
Okay. Ms. Grubb, anything for the record?
Judge, I think we just want to warn everybody that we set aside the whole day for Dr. Ely, wanting to make sure he got done, and with the knowledge that we were breaking a little early tomorrow. Now, Ms. Ms. Menashe said that she might not spend all that much time on cross. So we've been scrambling to get other witnesses here, Judge, but no one's stepped up yet. So we want to give everyone a heads up. That's all we have now. If we find someone that's able to come in tomorrow, we're even going into like the family members and stuff. But so far, we haven't been able to find anyone that can clear their schedule on such short notice. So we might be breaking very early tomorrow, depending on how things
We
go.
can't afford too much more of this.
Judge, we're going to
getting
ramp it way
behind
up here. We ramped it way back because we had the issue of, people out in the hall for 2 days at a time. So we're going to try to ramp it up big time next week. So we won't.
Okay.
I hope we don't run into this again.
Mr. Lapita, you're on the floor. Anything further?
Clear on.
Okay. Have a good evening.
Thank you, Judge.
Thank you, Ryan.